Bismillahirrahmanirrahim. Assalamu alaikum. This is Rehana Ilahi, the Director of Nursing, Shaukat Khanum Memorial Cancer Hospitals. It's my pleasure to welcome to all valuable participants to the 20th Shaukat Khanum Memorial Cancer Symposium. Accepting the challenge of COVID-19 and encouraged by successful virtual meeting of last year, this meeting is going to be held again in as virtual meeting. And while making it possible, many of us to attend from our home and workplaces. So every year, annual symposium has been a unique and knowledgeful event where nurses from different disciplines, national or international levels, they come together and share their work and expertise. So this session also started on with the pre-symposium workshop on Thursday, and we had a successful day yesterday where there were multidisciplinary sessions of the symposium plan. Today, with other multidisciplinary sessions, we have two nursing sessions in this symposium. Our first session is a plenary session, which is titled as or themed as Resilience of Professionals or Nurses Working in Cancer Care. So this session, in this session, the renowned nurse leaders from international and national institutions will enlighten us with the work and the valuable discussion on the crucial theme. We will have a second session, which will be in the afternoon as per Pakistan Standard Time, 14:15. That session is about developing compassion and dignity in nursing care. So the experience of every year, Cancer Symposium enriched with a great deal of scientific knowledge and evidence-based practice prevailing globally in management of cancer. So I'm grateful to all of you, all those healthcare professionals who have joined us, are about to join us in this unique scientific event. And we believe that we will be able to make this event an exciting opportunity for all of you, all of the healthcare providers, nurses, and those from the other discipline of healthcare. So my wishes to you are to have a good and great day. So the start of the program of today's session, which is Resilience of Nurses Working in Cancer Care, we have a keynote address. That keynote address is of our Shaukat Khanum's good friend for the last 2 years, Andrew Dymack. Andrew Dymack is a Chief Nursing Officer in Peter MacCallum Cancer Centre, Victoria, Australia. He has been friend and been involved in managing our educational activity symposium since last 2 years. So we are grateful to have Andrew with us today, and we will be enlightened by her talk. The topic of her talk is resilience and support of caregivers. So over to you.
Hello, my name is Andrew Dymack. I'm the Chief Nursing Officer at the Peter MacCallum Cancer Centre in Melbourne, Victoria. Firstly, I'd like to thank you for inviting me here for this keynote speech. In particular, we're looking at resilience and support of caregivers. So again, an enormous thank you for the invitation to speak at the Shaukat Khanum Cancer Symposium in 2021. So the areas that we're going to cover in this session is just giving some background, look at the resilience as a definition and what the literature shows, context in cancer, caregivers of cancer survivors, some interventions that we can all put into place, and to summarize our session at the end. So for the background, from the background perspective, just for myself, I'm an Australian trained nurse from Wollongong in New South Wales, and I've worked in Sydney, the Republic of Ireland in Dublin, and London in the United Kingdom. My background is a cancer and a critical care trained registered nurse, and my current role is the Chief Nursing Officer in an acting position at the Peter MacCallum Cancer Centre in Victoria, which we'll talk about briefly. My previous roles have been the acting chief nurse at the Royal Marsden Hospital in London. So my other roles, which I'm involved with, is in the International Society of Nurses in Cancer Care, or the ISNCC, where I'm a board member and the chair of the Member Development Committee. So a little bit about my background in terms of where I'm currently working. So as you're aware, the Peter MacCallum Cancer Centre is in Melbourne, Victoria, in Australia, and it's a world-leading cancer research, education and treatment centre. It's Australia's only public health service that's solely dedicated to caring for people affected by cancer. We have over 3,200 staff, including 700 staff that are laboratory and clinical researchers. So it's an integrated model where the research is happening in the same building as treatment is delivered and care is delivered to patients. And our focus is on better treatments, better care, and a potential cure for all cancers. On the bottom left-hand side, you can see that's a picture of the Peter MacCallum Cancer Centre. So the International Society of Nurses in Cancer Care, which is what I'm also affiliated with, and proudly here with you as well, is an international membership organisation of oncology nurse leaders, and we're dedicated to improve the health and well-being of people at risk for living with cancer. So our role is a leader for international full member societies, such as the Pakistani Cancer Nursing Forum. It was established in 1984, and our vision is to lead the global nursing community in control of cancer and to maximise the influence of nursing to reduce the global burden of cancer. My particular area or portfolio is the Member Development Committee, where I work to increase capacity and develop new cancer nursing societies. As an example, our most recent cancer nursing society that has been developed is the Ethiopian Oncology Nursing Society. So what is resilience? And again, we talk about resilience in many ways, particularly for our patients and our carers, our staff, and in many ways, those around an individual when they're delivering care. So there's no clear agreed definitions. And in particular, what we can see is resilience, it's a multi-dimensional construct. We know that resilience is a dynamic process, and you may be resilient at one point in a trajectory, but also in other times you may not be resilient, depending what's happening. And many pieces of the literature show that it can be developed or learned. So people facing consequences of adversity, such as stress, they can have a positive outcome as well from an experience. And adjusting to these experiences that is what's perceived as threatening. So these can all start from an exposure to a potential traumatic event. Now that could be a diagnosis, it could be news about a family issue, or it could be a financial consequence. One particular definition from the American Psychological Association to try and define what resilience means is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant source of stress. For example, family and relationship problems, serious health problems, or workplace and financial stresses. So if we're thinking about that particular definition, that can cover some of the areas that our caregivers in cancer care may experience. So again, just looking at some examples of what the definition of resilience might be. So in a particular article by Palacio in 2020, a systematic review was undertaken. And what was reviewed was looking at the construct of resilience and the variables around those constructs, particularly around caregivers. So for example, patients with chronic, advanced illness or end of life. And again, many of our patients can fit into these categories in cancer care. So this particular piece of research showed that there were 23 quantitative and qualitative studies. So again, small numbers, but they've described the role of resilience in adaptation and coping in caregivers, and that they also showed that that resilience associated with positive impact on quality of life and emotional distress. What was found is communication and social support increased resilient coping strategies. So in conclusion from the finding of this paper, there was that the resilient coping strategies reduced distress normally resulting from illness related to changes in the biophysical and the spiritual dimensions, and to promote adaptation of the caregiver. So we're going to explore that a little bit more. So what does this mean in the context of cancer? So again, we're all aware, cancer is one of those most common issues that we have in our healthcare systems, and many of us will experience cancer ourselves or part of our families or our wider networks. So from the WHO's definitions, we know that 18.1 million new cancer cases reported each year across the world, and our survival rate for cancer has been increasing, which is fantastic. However, the advances in medicine and technological innovations are varied across the different countries and regions across the world. But we do know that survivorship includes physical, psychosocial, financial effects, and family caregivers are part of this. And caregivers are important providers to support for cancer survivors. So again, this is very different in the different context of where we are working and living. So if we then look down in terms of caregivers, in particular around cancer survivors, as one aspect. So cancer can be perceived as a life-threatening or a crisis for a family member or a caregiver. So we know up until the early stages of diagnosis, through treatment, and through the survivorship or end of life, that the family or the caregivers are with our patients at all the times. However, these caregivers are trying to adjust to the new diagnosis, for example, or treatment pathways, or the end of life and palliation in a different way to what the patient may be experiencing. So we know that caregivers have the ability to acquire new strengths and social resources. So this is where care groups come into play, social networks, in many ways these days around some of the social media platforms where people can share their experiences of a shared experience. We do know that potentially traumatic events can have a short and long-term effects on the caregivers. So again, another piece of research in 2020 looked at particularly caregivers in Turkey. So what was important in this piece of research was that the cultural context is really important, especially where family caregivers are the only option for cancer care. So as we know, irrespective of where we are in the world, that there are certain aspects of family who are involved directly with cancer care or delivery of care, and those in other areas where it's very much around a hospital setting or a hospice. So again, it's looking at the context of the region and the culture that we're working in to ensure that we include our caregivers to a degree and what support they need as well, depending on where we are. So again, if we're looking at cancer and caregivers, we know that this particular group may be at risk of a psychological, physical, or social dysfunction. So they can display symptoms of depression, anxiety, fatigue, sleeplessness, and social isolation. So for us as caregivers or healthcare staff, we are able to pick up some of these key symptoms of a caregiver. And for us, it's then trying to work out how we then support them. And there might be some direct interventions, which we'll talk about in a moment, or some directed care to another facility. But we also have to recognize that they may not experience any trauma, and some of those caregivers may develop resilient processes, including a benefit of caregiving, so they find it therapeutic. However, many caregivers fail to seek help for themselves, so they are very much consumed looking after their family member or their loved one, and they see themselves as a second part of that process. So we then need to look at the medical and or psychological assistance that can come in too late if unrecognized. So we know the consequences of those where we see the untoward consequence of a caregiver who's not being supported themselves. Just as another example, particularly looking at children, so parents or caregivers of children with cancer. So Rosenberg looked at this in 2013, and in particular what we see here is that the mechanisms are broken down into three areas. So baseline resilience, evolving resilience, or resilient outcomes. So in terms of the baseline, it's looking at inherent traits of resilience. So again, things that we may be born with, so our coping mechanisms. So somebody being born with some optimism or some clear self-esteem that is different to somebody else. And in this study, they also identified some of the socio-demographic areas that may also contribute. So it might be prior education, the structure of the family or the wider community, and the social support that they may encounter. So again, that experience of life may, in this paper, describe how they then go on to become resilient or cope or may not be able to cope. The second area is evolving resilience. So this is where the resilience changed over time. At the early stage of a crisis, there is an ability to cope or to be resilient, and that may wane over time depending on what's happening or the length of the crisis period. So we're looking at here hope or coping skills, and in particular, there's the support from other caregivers. So in parents with children with cancer, very much so that networking, particularly in the clinical area, sharing a shared experience, and also the ups and downs of the child's care also helps that resilience. but in other areas around that communication provider interaction. So how we interact with the parents and or other caregivers when we're delivering cancer care to our patients and their caregivers. And finally, it's the resilience outcomes. So it's looking at the ability to care for themselves and the children, particularly after loss in this example. So that therapeutic component of being able to move on beyond that, and that there's an outcome at the end of that. So this just gives an idea of a conceptual framework. So it's from the diagnostic or the diagnosis through treatment and that long-term follow-up, there might be survivorship, and in some cases may lead on to palliation and end of life. So we have the early part of our perceptions and our appraisal of our perceptions, the evolving resilience over time, the baseline characteristics that are the basis, and the resilience outcomes that build up over time as well, from the lower bits initially and then a bit more as we go on. So again, it's talking about those potential interventions. So at those points of diagnosis, treatment, and long-term planning, but particularly around the evolving, the baseline, and the resilience outcomes. So if we break down again into those three areas. So if we think about baseline resilience, generally it's not modifiable. So we might be able to enhance it by recognizing particular areas of resilience. For example, fostering protective characteristics. But again, things like generally age or other of those other protective characteristics we're unable to change. If we then move on to the evolving resilience, then this is potentially modifiable. So for example, they may be able to foster enhanced interactions with us, the healthcare staff, by communication and supportive care. So for us, recognizing that we may need to intervene and look at some social work, psychology or psychiatry for the caregivers. And again, finally, the resilience outcomes is looking at the other potentially modifiable interventions. So these could be directed interventions such as self-care and good quality of life. So again, the caregiver seeking and being able to change their processes and thoughts going forward. So what are our interventions options? So there are three potential areas that we could look at. And again, it's looking at putting these together into particular themes. So first one's around knowledge and information. So supporting the caregivers with information. So bearing in mind, cancer patients and caregivers would receive a large number of information leaflets, whether it's electronic or paper-based. And again, it's trying to find out the right time for people to access that information, but also to identify what is appropriate. So we don't want to overwhelm them. We want to make sure it's a personalized approach and ask them what information they would need. And that may then lead on to actually us being able to identify what they could also require. So you could also look at some personalized coaching. And what has been identified in the literature is the use of video conferencing. So particularly around group sessions, but more so in our current climate where we're unable to meet together in large groups, but there's an ability to still connect with others. And that can then have an impact on the quality of life. The positive psychological activities are looking at promoting well-being. So this is for the individual themselves. So again, referring on our caregivers for interventions such as meditation, cognitive behavioral interventions, and again, that might need professional intervention, but also the strength of sharing stories and similar families. So again, just going back to our parents of children with cancer, this is particularly important, that shared experience of their journey and that their loved one has gone through. And finally, another intervention could be around social support. So the ability for our caregivers to ventilate feelings and look at their coping strategies. Again, bringing that peer support mechanisms in place, looking at groups beyond the acute phase of their treatment, and then in some cases coming back to a cancer center, for example, and sharing their experience of cancer as a survivor for not only patients but also caregivers about what that experience was like, and helping us to deliver the new future care and the future care pathways that we need to do. So overall, that joining of networks or support groups, and this is particularly important with rare cancers, when the exact shared experience may not be the same as somebody else. So in summary, what we find is that there is no clear definition of resilience, particularly for caregivers. There are a limited number of studies addressing caregivers' resilience in adults and children, and particularly around cancer, there is even more limited. But we do know there are intrinsic and extrinsic resources that are able to facilitate or hamper resilience. So again, just looking at the individual. We know that there is little known of how resilience resources interact. So we have some resources that we can use, but further studies required to understand actually what impact that does have. There are no clear predictor variables for the resilient trajectory, and the development of a prevention program and treatment options are required. But what we are also aware of, that interventions can support some caregivers, but we need to do further research on that. So just to end with a quote from Victor Hugo. So when we're thinking about our caregivers going through an experience alongside of their family or their loved one, is that even in the darkest night will end and the sun will rise. So again, think about the difficult times that our caregivers go through. We're alongside them, and there are interventions that we can guide and direct them to ensure that they are equipped with the right information, resources, and connections to make sure that they can go on to care for their loved one, but also their wider family and community. Thank you. I'll finally end with some references there for your follow-up, and now open up for any further questions.
So, as we all have listened from Andrew's talk, that cancer can be perceived a life crisis for family and caregivers. It's a potential traumatic event, of course, for the family, for the caregiver, sibling, and all those who are involved in the care. In our culture, particularly in Pakistan, where the family, the context, the family is very much involved with the patient physically, mentally, socially, and economically, and they are suffering when a patient is suffering. So they need to have and they have psychological effect, they have physical effects. We in our day in and day out clinical practice all experience that. So they need to have coping strategies. And as in Andrew's presentation, we need to do more research to search out what is happening in our context, how much the caregivers are experiencing effects, and what coping strategies can be done for them. So linked to the theme and to this session, our next speaker is Dr. Nasreen Suleiman Lalani, a good friend of mine, and I'm proud to say she's one of my classmates in our undergraduate degree. Ms. Lalani is an assistant professor at Purdue University, Indiana, United States, America. The topic of her talk is resilience of nurses working in cancer care. Over to you.
Salam, everyone. Thank you, Shaukat Khanum, for giving me this opportunity to speak to my own colleagues back home after a long time on a topic which is very close to my heart, that is psychological trauma and resilience. Just before starting the presentation, I would like you to know that most of my nursing experience was from Pakistan, and I worked for almost 20 years in medical, surgical, and hospice settings, and hospice and palliative care settings. And while making this presentation, I was kind of reflecting on all those experiences and stories that I had during my nurse experience in Pakistan. So I could relate to most of your nursing experiences and the system and environment which kind of we experience in Pakistan during our work. So just going back to the objectives of the presentation. So the objectives of today's presentation is we will talk about psychological trauma and different types of trauma. We will also discuss various factors that can cause nurse-specific trauma in healthcare or cancer settings per se. We will talk about the manifestations that a nurse can have who is experiencing the psychological trauma. We'll talk about resilience, and we will identify the ways to promote resilience, and have some recommendations to promote our self-resilience as well as for the organization in which we are working. So before starting the presentation, just I wanted you to look at some of the news clippings that is very recent, And these are kind of portraying the experiences that the healthcare professionals are currently going through during the recent pandemic times. So one of these clipping is basically a story of a doctor who committed suicide because he cannot cope with the trauma and with the work pressures he was going through. And there are other stories also which tells us about the grief and how to deal with those grief among our patients and families, and how we as healthcare professionals are affected from those grief and dying experiences that we have in our day-to-day work settings. So just take a few minutes to reflect on these news clippings and reflect on the current experiences that we are going through during these difficult times. So as I said, that healthcare professionals experience different forms of psychological trauma, which can be vicarious trauma, secondary trauma, or workplace violence. And that could be because of the increased workload, the staffing ratios that we have, the lack of training and resources. Those are the major factors that contribute to a trauma, especially in cancer and palliative care setting. It's often difficult to deal with dying patients and their families and their pains and sufferings, and sometimes communicating to them that, oh, you are dying, or you are left with these many days, or even seeing a patient with a lot of side effects of chemotherapy or going through other pain. It's not easy for the working professionals. So as a result, we do experience a lot of burnout, compassion fatigue, job dissatisfaction, and sometimes the healthcare professionals tend to leave their profession, or they migrate to different countries for better job prospects or for better job work conditions. So this is a very interesting slide. This slide is basically showing you two faces of a nurse. One face which is commonly seen by the public. Usually the public sees us as an angel, whereas we as healthcare professionals are termed often in the literature as wounded individuals. But we are also at the same time wounded healers, because as nurses, we have the capacity to transform and transcend our own painful experiences, and we help the patients to heal therapeutically, while at the same time we also suffer and have the pain, but those pain is often masked and we often hide our own scars. So from becoming wounded soldiers, we become wounded healers. So this is a model which is being developed by one of my colleagues at Purdue University, Dr. Karen Foley, and this model is based on the data that they collected from interviewing the nurses at different settings. And this model is basically talking about different kinds of trauma that nurses go through and how we can help the nurses going through this psychological trauma. So what this model is actually saying is that every individual, every nurse, or any healthcare professional perceive trauma in a unique way. There could be a lot of factors that may be influencing that trauma. It could be genetic, biological, familial, psychological, cultural, spiritual, and environmental. And there could be both positive and negative outcomes of trauma. So the negative outcomes of trauma may include anxiety, depression, substance abuse, smoking, and other mental illnesses or conditions. Whereas the trauma could be positive, have a positive influence on the healthcare professionals. And that depends on the resiliency. So resiliency and post-traumatic growth actually acts as buffers and can have potential positive outcomes for certain psychological traumas. The self-care and the organizational strategies that support the healthy working conditions and provide sufficient resources for the healthcare professionals to prevent burnout and to promote resiliency can reduce the impact of nurses' psychological trauma, and we will speak about those recommendations in the following slides. So let's talk about what are different types of trauma. There are different types of trauma, and these are given on the slides if you want further explanation or clarity. So in the matter of time, we will discuss it briefly, the types of trauma. So one could be vicarious trauma, which is witnessing other people trauma. For example, if you are experiencing the death of a patient and family or experiencing their pain. Historical trauma is basically the trauma that is generated, that is transferred from the generation. So for example, if you have seen your head nurse bullying you or doing horizontal violence to you, so there is a probability that when you become a head nurse or when you take that role, you will have the same behavior or same attitude with your junior colleagues. And we know that there is a common saying that nurses eat young. So this could happen consciously and unconsciously. Then there is workplace violence trauma, which is about the verbal or written or physical abuse that could be from our patients, our visitors, or from our colleagues, and it could be from a nurse to another nurse, which is often termed as horizontal violence. The system-induced trauma, sudden diagnosis or healthcare treatment that causes the individual to experience trauma, or insufficient resource trauma, where you do not have enough resources or enough training or enough support from the organization to combat with your trauma that can cause a trauma. For example, if you are helping a patient in her own, if you want to give counseling or psychological support to the patient or family, but you do not have enough training to do that with your patient and family, and that can cause trauma to yourself. Then there is another second victim trauma, which can be maybe happen as a result of any error. For example, if you do any medication error or documentation error, so those kind of incidents can cause trauma in you. And the last one is trauma from disaster. So we can take the example of pandemic or any disaster that caused trauma, for example, floods or earthquakes or any other disaster. So now, what is resilience and personal growth? So the literature states that despite of all these trauma that the healthcare professionals experience in their work life situations or in their own daily life situations, some individuals have the capacity to transform and transcend that trauma, meaning they have the capacity or they have the resources to cope with that trauma. And that capacity is often referred to as resilience. So resilience is basically the ability to bounce back, withstand adversity or difficult life situations. For example, some individuals have the capacity to navigate or find ways and resources to find meaning in their work. So those individuals who are resilient, they have more capacity to rise up and they see their work as rewarding. And those things can act as a buffer for their own well-being. And those could bring positive outcomes rather than negative outcomes of whatever trauma they are actually experiencing. So these are some of the factors that can lead to burnout. So there could be physical stressor, there could be psychological stressors, or there could be institutional stressors. Physical stressors could be like you're working under unsuitable condition, long working hours, insufficient tools and equipment that is not helpful or not resourceful for the staff, can cause frustration, can cause fatigue among the nurses or the healthcare provider working in the hospital or hospice settings. There could be psychological stressors. For example, there are too many symptoms related to disease and treatment, increased expectations of patients and families, and problems related to occupational safety. The last one is institutional stressors, which could be not having the healthy working conditions or unsatisfactory salaries or incentives. This could cause trauma or burnout or exhaustion among the people working in the healthcare setting. The manifestations of psychological trauma could be physical, emotional, social, or spiritual. The physical, sometimes we know that when we work for longer hours or we don't have good working conditions, there is a probability that the nurses or the healthcare providers may find fatigue, tiredness, headache. You have physical illnesses. You have insomnia, that is lack of sleep, lack of appetite, or you may end up in having chronic pain. There could be emotional manifestation of psychological trauma, which includes emotional exhaustion, irritability, anger, lack of interest in daily activities, which we are sometimes finding during the pandemic work situations. We were hearing a lot of healthcare professionals talking about all these symptoms. The person may isolate herself or himself from others. There could be a feeling of loneliness, and there could be spiritual symptoms also, like we don't find meaning in our work anymore. We just want to quit the work, or we just don't see any personal achievement. We don't see any reward in whatever we are doing, or we just depersonalize ourselves from our work. And we have developed non-human attitudes toward our own job or toward other people. We don't have good relations with our own colleagues and with our own workers during the work. So these could be the manifestations of psychological trauma. So how can we develop our resilience? So there are different factors that we can develop our resilience. One is self-perception or positive attitude. So self-perception is about how we think about ourselves, how positive we take all our scenarios or whatever is happening in our daily lives. So how we think about ourselves, like, do we think positively, or are we very much reactive or have the negative thoughts about whatever we do? So how we perceive about ourselves, it makes us resilient. Then whatever these available support system is very important to develop the resiliency, because how can we be positive if we don't have support or we don't have the resources from others? For example, if we don't have good friends or family or good colleagues, it's difficult to be resilient. So available support system is very important. Do we have someone where we can share or ventilate our negative feelings? So that is very important to develop our own resiliency, our own ability to cope. Social competence is another, that how we connect with our friends and family and how much support is available again. And then communication and coping skills are very important to develop our own resiliency skills. And then family cohesion, which is our own harmony with those closest to us. So these all resources are very important to promote our own coping skills and to combat with our own burnouts and compassion fatigue. So these are some of the strategies that we can use to prevent burnout and promote resilience. So one is, as I said, that your own self-management is very important to prevent stress and burnout. We need to adopt a positive attitude and be grateful of the things we have. So gratitude and forgiveness are very important principles that if we adopt in our lives, we can prevent burnout and we can improve our own coping skills. The other thing is organizational structure. The organizational support and healthy working environment is the most important thing to promote our resiliency. Then education on self-management skills is also very important. So programs like psychodrama, relaxation techniques, deep breathing exercises, having some counseling sessions, sometimes doing yoga, exercises, talking to friends, taking some break, going out for vacation for a little bit of time, or involving yourself in some recreational activity or whatever you like. I think it depends on individuals' coping ability and also the resources. So one strategy might not work for all. So everyone can have own self-awareness about her or his own self coping abilities. So for instance, some people find it helpful to talk to their friends. Some people find it helpful to have some blog writing for coping, or some people do the diary writing for their coping. So it depends on your own individual interest and on your own resources and on your own capabilities. Some people like to have exercises, some people like to have music. So any strategy that help you coping with the burnout and promote resiliency, that could be helpful. So this is my last slide, and this is very interesting to read, that being human is a guest house. Every morning is a new arrival, a joy, a depression, a meanness. Some momentary awareness comes as an unexpected visitor. Welcome and entertain them all. Treat each guest honorably. The dark thought, the shame, the malice, meet them at the door laughing and invite them in. Be grateful for whoever comes, because each has been sent as a guide from beyond. And this is by Rumi. And I seriously like it, because good and bad days come in our lives. There are difficult times, there are adverse situations. During the pandemic time, we have seen a lot of adverse stories, a lot of negative things. But at the same time, we also see some sunshine. We also see some innovations in our models of care, and we are learning at every step of our life. So that's how resilient we are, and that's how we can promote our resilience. So thank you very much for this session, for inviting me and talk to you people in this session. I hope you liked my session. And if you have any questions or queries, I have given my email on my first slide. That is lalani@purdue.edu. So feel free if you have any questions, concerns, or queries, and I'll be happy to respond to those. Thank you.
So back to the session, we have Dr. Lalani with us, and there was a question from one of the participants, Basharatullah. He asked the question from you, Dr. Lalani. Are you with us, Dr. Lalani?
Yes, I am here.
Yeah. So this is Rehana talking to you. Basharatullah is asking that working on a unit, a clinical nurse manager of an oncology setting, how would you suggest that they can promote resilience in their nurses working on bedside? Could you please like to respond, Dr. Lalani?
Yes, so that's a very good question. I think sometimes it becomes difficult if there are other struggles like staffing ratio and workload crisis, but definitely we have to be supportive to our staff, and our systems should be such that they should support the staff. So I think the system play a bigger role, and also as individual. And we will also talk some of the strategies in our next session that is on compassion. So compassion is very important. So that means that we have to be empathetic to our staffing concerns, whatever they are saying to, and we should be able to give a listening ear to them. And also, as I said, that distributing the workload is another important strategy, and also looking after their self-care. So having a counselor, if they are going through any mental stressors, we should provide them some counseling activities. So again, I would summarize that being compassionate, giving a listening ear, reducing the staff workload while having a good distribution of staff on the floor, and organizational support, that is system support, is very essential to promote the resilience among staff.
Okay, thank you, Dr. Lalani. We have another question from one of our friend, Lubna Ghazal. She is going to be a panelist in the afternoon session. She's asking, how about initiating psychological services for nurses and doctors in the hospital?
Yeah, that's very crucial, because during my presentation, I showed some of the newspaper clippings And that's again rising. The mental health crisis is increasing, and especially after the pandemic, we are seeing that a lot. And it's not limited to Pakistan only, but it's throughout the globe. So it's happening both in developing and developed world. So it's a very good initiative to start mental health counseling. I don't know about Pakistan, but definitely in US and Canada, we have a crisis line which we provide to the healthcare providers. So whenever they feel like, because it's a very confidential thing, and there must be some of the staff who do not want to share their things to others. So there is a confidential crisis line, and we provide that crisis line number to everyone. And it could be reachable to everyone, and they can contact there, and there are mental health counselor who help them. So definitely at organizational level, also in different hospitals and different universities, we have mental counseling services. And these kind of services should be provided to the staff and also to the students within the organization also, to help them cope with their mental health and if they are going through any traumatic situation. Because if we won't help them, then it could result in negative outcomes like depression or suicide or other things. So Lubna, this is a very good idea, and we should have those initiatives at our organizational level also, and at the PNC level also, and also at the country level.
Okay, so I would like to add, and Bisharat have already responded, that we as an oncology setting have this setup available to our nurses and doctors and other healthcare providers, where they can go and see the psychologist for counseling whenever they feel. And because, as you said, it's a private and confidential matter, so nobody interfere in that. The nurse manager help them to set their appointment in there. Secondly, because we are JCI certified hospital, and as per requirement of the hospital, we do second victim counseling for people who go through the what you call it, any error or something, to they suffer psychologically, and during COVID we used to have sessions which were all for nurses, because the COVID pandemic was a new situation. All that, families are affected, patients are affected, nurses working at hospital unable to take care of their self and their family. So we used to have these sessions for them. So thank you very much for Dr. Lalani's session. Oncology nurses work day in and day out under the stressful conditions. So when their patient and their families suffer in pain, or they suffer the grievance, they also suffer. Nurses, as human beings, they also suffer physically and psychologically. They also have traumatic psychological effects on them, and that eventually make them leave their job or the profession. So to help them out, and they need help, they need resilience. To help them out, as Dr. Lalani have mentioned, that we need to have personal traits which help them: positive thinking, deriving your coping strategies, looking into the positive aspect of patient care, and also patient and their family, the friends and their family of the nurses help them to cope up with the situation, as well as organization have a bigger role to provide support to nurses so that they can take that resilience to them. So next, linked to this topic, we have another talk, which is determining professional quality of life of oncology nurses working at Cancer Center in Pakistan. This is a research conducted by one of our nursing lecturer practitioner in the past, Ms. Naseem Yusuf. When she studied this topic, she was working at Shaukat Khanum Memorial Cancer Hospital. She's an oncology specialist nurse and a teacher. Currently, Ms. Naseem has moved to England. She's working as in the oncology setup in Eden Brooks Hospital, Cambridge University Hospital, Cambridge, United Kingdom. So over to you.
Bismillahirrahmanirrahim. Assalamu alaikum and good morning, everyone. I'm delighted to present my thesis at this forum because this particular study was done at SKM, and I was inducted to present it here. The topic of my study was professional quality of life in oncology nurses working at a cancer center in Pakistan. And I'm also glad that the topic of my thesis was very much relevant to the theme of this symposium. So let's start with the introduction. So we all know cancer. It is a disease that brings lots of physical, emotional, and spiritual challenges for patients as well as the supportive people around them. And these supportive people around cancer patient mainly includes the family because they face the challenge of caregiving and unexpected changes in their family process. And then the healthcare providers. Among the healthcare providers, the most prominent position is held by oncology nurses because they fight at forefront of cancer and they barter the suffering of their patients and their families. So oncology nurses are in a unique position to help their patients in most vulnerable times of their lives. They owing to the cancer as a disease and its treatment, oncology nurses develop a very strong connection with their patient that is frequent, that is continual and long-term. So as a result, they become the companion of their sufferings, not just the caretakers. So while working with cancer patients, oncology nurses face increased vulnerability for immense emotional burden and physical distress. So this distress comes from witnessing the traumatic events of their patients. We all have seen our patients deteriorating suddenly and unexpectedly. We have seen our patients dying in front of us, and we witness our patients' unmanageable pain. So in addition to this distress, there is increased work-related stress as well. So this work-related stress is not just the scarcity of resources, but it's more about the healthcare politics and the policies. The nurses may have declined management support. They face staff shortage, shift patterns, working long hours, and then high patient acuity, immense workload, and all that. So all these factors work together to hinder oncology nurses' ability to provide compassionate care, which will ultimately impact their professional quality of life. So the concept of professional quality of life used in this study is adapted by STAM, who describe it as professional well-being of a person who is working as a helper. So he explains that the person can come across, when the person is working as a helper, he or she can come across both positive as well as the negative emotions. And the negative emotion, positive emotions here are referred to as compassion satisfaction, while the negative emotions are known as compassion fatigue. And compassion fatigue develops when a person experiences burnout and secondary traumatic stress. And the professional quality of life is measured by determining the level of these emotions in any person. So here the professional quality of life is a triad of compassion satisfaction, burnout, and secondary traumatic stress. So professional quality of life is considered central to nurses, but there is scarcity of literature discovering professional quality of life in nurses. There are lots of profession that has been studied for this concept. There are psychologists, teachers, policemen, fire brigades, and all this, but there's very few studies existing in the field of nursing, and those which are done in fields of nursing are done in other critical areas of nursing, like for example emergency assessment rooms, critical care nurses, operating room nurses, but their findings are not applicable in oncology nurses. Why? This is because of the unique nature of nurse-patient relationship in oncology nurses. So there's a need to conduct such studies in the field of oncology as well. So this study was planned in anticipation of identifying both the positive and negative emotions of professional quality of life for nurses working at SKM. My study hypothesis was that the nurses at SKM would experience higher levels of compassion fatigue and lower level of compassion satisfaction, and that the demographic and work-related variables are associated with nurses' perception of professional quality of life. So this was a cross-sectional analytical study And the setting, it was done at Shaukat Khanum Memorial Cancer Hospital and Research Center. And study population included the nurses who are involved in direct patient care in inpatient units, chemotherapy department, emergency assessment room, and intensive care unit of SKM. So I included the nurses who are working with cancer patients for more than 1 year. Though this 1 year doesn't seem sufficient to call a nurse as oncology nurse, but this was because of the high nurses turnover during that period of time. There were very few nurses who were meeting the criteria of the studies because most of the nurses were new. So I just kept it limited to the 1 year. And then the nurses who were involved in the direct patient care, and I included both male and female nurses. So the exclusion criteria, I excluded the nurses who are rotated from OPD, OR, radiation, and nuclear medicine to the areas considered for the study, and for less than 1 year's time. And obviously those who were not willing to participate in the study were also included. So convenient sampling technique was used. All the nurses who were fulfilling the criteria were invited to participate in the study. So 2 questionnaires were used to collect the data. The first one was socio-demographic details that was built by the primary investigator, and the other one was professional quality of life scale, commonly known as ProQoL. And this scale it was developed by STAM. It includes 30 items questionnaire that consists of 6-point Likert scale. So this was an already validated scale, which was downloaded by their website by filling in a permission form. So in order to collect the data, I approached all the nurses working in the areas under study. I approached the nurses in different shifts. And after disclosing the essential and relevant information related to the project, their written informed consent was obtained. And then they were handed over a self-administered anonymized questionnaire, and they were followed up a day after to clear the questionnaire back. So this was because I didn't want them to fill the questionnaire at that time, because they might have been occupied with many other things related to their patients or their duty, and they might not have given the true reflection of their experience. So in order to have more accurate responses, I gave them some time to fill the questionnaire. So the data was analyzed using IBM SPSS 20, and the participants' gender characteristics and ProQoL was measured using frequencies, percentage, means, and standard deviation. Chi-square test was used to analyze the correlation between demographic characteristics of the participants and ProQoL score. T-test was employed to determine the significance of relationship among the variables. So before starting the study, approval was gained by a research approval committee of Masa University, Malaysia, the scientific review committee, and institutional review board of SKM. And then participants' rights were ensured following the institutional policy. So now the results. In demographic characteristics, we can see that most of the nurses included in the sample were male, and most of the nurses were married. The medical oncology made the most significant part of my sample. So in order to, regarding the grouping of the nurses under area of practice, I didn't group them in the wards they were working in. But I grouped them as per the service they were provided. Like, for example, for medical oncology, so the nurses who were working in chemotherapy, the nurses who were working at IPD 2B and IPD 3, they were grouped as medical oncology, and the nurses from the nurses who were working as a palliative care nurses in IPD 3, IPD 2, or IPD 2A, so they were grouped as palliative care nurses. So medical oncology formed the biggest part of my sample, and 69.2% of the nurses were educated to a diploma level. And then most of the nurses, that was 36.2%, had more than 10 years of experience working at SKM as oncology nurses. And then majority of them, that was 54.6%, were working as senior RN or RNs. Coming to the scores of the subscales of ProQoL, we can see that the mean score for compassion satisfaction was 40.8 with standard deviation of 5.5. For burnout, it was 33.1 with standard deviation of 4.2, and the mean score for secondary traumatic stress was 27.9 with standard deviation of 6. The results from each subscale of ProQoL were also analyzed to determine the level of each subscale using the cutoff score as determined by STAM. So data for compassion satisfaction subscale showed that 71.5% of the participants were experiencing an average level of compassion satisfaction, while 28.4% were experiencing high level of compassion satisfaction. None of the nurses showed a low level of compassion satisfaction. So data regarding burnout indicate that a majority of the nurses, that is 98.4%, that is the significant proportion of the nurses, they were experiencing an average level of burnout, while just 1.5% were experiencing high level of burnout. None of the nurses were experiencing lower level of burnout. So coming to the secondary traumatic stress, it was also high, as 83% were experiencing an average level of secondary traumatic stress, whereas 16.9% were experiencing lower level of secondary traumatic stress. So based on these findings, the key areas of focus became the existence of burnout and secondary traumatic stress, and ultimate compassion fatigue in these nurses. So association of ProQoL with demographic variables, we used t-test to compare the levels of ProQoL and subscales with study variables, and the data was presented using the crosstabs. So here is the crosstab analysis of demographic variables and compassion satisfaction. And we can see that area of practice is the only variable that is significantly associated with compassion satisfaction, with a p-value of 0.004. And here, the nurses from medical oncology, 37.3% of the nurses from medical oncology were experiencing moderate level of compassion satisfaction. And among high level of compassion satisfaction, the biggest number is 47.6%. And this is again the nurses from medical oncology department. Not just the medical oncology department, the nurses who are working, who are delivering the services as medical oncology. Looking into the crosstab analysis of demographic variables and burnout, we could found that none of the demographic variable was significantly associated with burnout. Here is the crosstab analysis of demographic variables and secondary traumatic stress. So here again, we can see that area of practice is the only variable that is significantly associated with secondary traumatic stress, with a p-value of 0.009. And here, the highest number is 54.5% of the nurses who had a moderate level of secondary traumatic stress, and these nurses belong to intensive care unit. And none of the other demographic variable was significantly associated with secondary traumatic stress. So here are the main observations of demographic variables and ProQoL. So most significant statistical relationship was found between compassion satisfaction and nurses area of practice, with a p-value of 0.004, and secondary traumatic stress and nurses area of practice with a p-value of 0.009. So those were the nurses working in medical oncology department had the highest percentage of compassion satisfaction. So scores of compassion satisfaction and burnout were relatively equal among surgical oncology and intensive care unit nurses, and lower score of compassion satisfaction and burnout were presented by the nurses working in pediatric oncology or palliative care. So the level of secondary traumatic stress was highest in nurses working in intensive care unit. So young nurses aged between 25 to 30 years experienced the highest percentage of compassion satisfaction and secondary traumatic stress. And the higher scores of burnout was observed in nurses between 31 and 35 years of age. So the nurses younger than 25 years experienced lowest levels of compassion satisfaction, burnout, and secondary traumatic stress. So the scores for all three subscales were higher in male as compared to the females. They were higher in married nurses as compared to the unmarried, and in diploma level nurses as compared to the nurses holding other higher degrees, and in nurses who are in RNs as compared to the other senior designations. So coming to the discussion, there were few nurses who have reported higher level of compassion satisfaction. But worryingly, the moderate level of burnout and secondary traumatic stress is prevalent in almost every nurse. So when I went to the item level analysis of the questionnaire, I could find out that almost every nurse have reported the feelings like depression, being worn out or bogged down and preoccupied. And they have expressed a degree of dissatisfaction with their job as a nurse and where the care is provided to the patients. So as per the findings of my study, a higher level of compassion satisfaction does not alleviate the risk of burnout or secondary traumatic stress. Whereas there are studies who have given the opposite results. They state that the compassion satisfaction and compassion fatigue have strong inverse association, where the higher level of one outcome cause a reduction in the frequency of other outcome, but this was not true in my study. So with only exception to the area of practice, we did not identify any significant difference in any of the subcategories, and the scores of nursing pertaining to the burnout and secondary traumatic stress are meaningful for the organization in order to improve the ultimate quality of nursing care and patients' safety. There are studies who have diagnosed the significant association of different demographic characteristics with the ProQol, but that is not true in my study. So the scores of my study suggest that the age between 25 to 30 years is most sensitive to any of the element of the professional quality of life, as the ProQol scores were higher in this age group, which followed a declining pattern before 25 and after 30 years of age. So the findings are congruent with some studies that have been done in the past. So the nurses area of practice was the only significant associated variable in the current study, and these findings are again supported by a few studies, and they have supported their findings by claiming that high patient equity, increased number of patient deaths, severe complication of cancer and its treatment, and critical symptoms are mainly the responsible factor for causing this association. And this is coupled with the poor staffing levels and extended hours. So as for the many studies, my study also had some limitations. First, the small and convenient sample from a single oncology institution is the inherent limitation of this study. And then heterogeneity of the sample is another factor. Our sample was composed of participants with varied characteristics. However, the representation from different age, qualification, clinical placement, and designation was not comparable. And other limitation adding to this is the wide age range. A lack of age gap and a narrow age range is substantial to produce more accurate and consistent results in relation to the each subscale. Hence, the generalizability of the study reaches as far as the variability of the sample and cannot speak to all oncology nurses in this region. A comparative sample considering all demographic characteristics is important to generalize the study to identify the clinical places or a certain group of nurses requiring particular intervention. So regarding data collection tool, ProQol is a widely used tool that has been used in nursing and non-nursing fields. But I would say that there should be a More accurate tool could be the one that is specifically designed for the nurses or the oncology nurses that could be able to produce more accurate findings. So conclusion and recommendation. Oncology nurses at Shaukat Khanum Memorial Cancer Hospital and Research Center are vulnerable to be inflicted by burnout and compassion fatigue with lower levels of compassion satisfaction. So work-related characteristics as nurses' clinical area and year of experience are modifiable risk factors, which can be considered to prevent compassion fatigue in oncology nursing. So provision of supportive work environment within the department must be ensured. So preventing compassion fatigue and promoting compassion satisfaction would have positive impacts on patient-related care outcomes and will strengthen Pakistani healthcare system. So nursing leaders and policymakers in the field of oncology should encourage more frequent surveys to identify instrumental factors related to compassion satisfaction, compassion fatigue, and burnout. This would serve as the basis for formulating best practices to ensure better outcome for nurses, patients, and the institutions. So here are a few of my references. So thank you very much. Thank you everyone for listening to my presentation. I'm very thankful to all the participants who have participated in my study. And obviously I'm thankful to my supervisor, Dr. Samsia, and others supporting.
Okay, so thank you very much, Naseem. Since you are with us, welcome, and your thoughtful results which you presented. We have one comment from a lot of the participants attending this symposium physically. Most of the nurses had a more than 10-year work experience at SKM in your study. Does it has impact on satisfaction level? What are your thoughts? Naseem.
Yes, Assalamu alaikum.
Yep.
So definitely, it is true that the nurses who are working over a longer period of time with any discipline, it may be oncology, it can be critical care, any type of critical discipline, they are at risk of experiencing more strong emotions. It can be like compassion satisfaction, or it can be compassion fatigue. It can be any form of emotions. So the best thing for these nurses is to providing them, like, of course, it is worsened with the type of clinical environment they are working in. For example, if a nurse is working in OPD for 10 years, she might not experience strong emotions as compared to the nursing who is working in critical care unit or who's working in inpatient. So the best thing for these nurses is to help them recognize their emotions at an early stage when they are just like experiencing some degree of burnout or some degree of secondary traumatic stress. If they are able to recognize their own emotions, it can really help to prevent any negative consequences of that.
Okay, thank you. Ms. Yusuf, we have another question to you by William Chaman. Is there any role of family in preventing burnout or compassion satisfaction or increasing compassion satisfaction? Or there is a role of marital status? I am sure that in your study, this was not highlighted, but maybe you have read in literature, or so would you like to comment on?
So it was one of my variables, but the assumption was, like, of course, I've taken this assumption from the previous studies, and the assumption was that the nurses who are married, because they are at the same time, they're struggling with their family stresses, they may have their children, work-life balance and everything, so it may worsen their stresses while they are observing the stresses of their cancer patients as well. But it's not proven in my study. So I think it's really depends. Sometimes your family is quite cooperative, so they can help you to maintain your work-life balance. And if they are not, then of course you are going to suffer a lot. So it really depends upon the type of your family you have, I would say.
So there's another question, and that will be the last question I'm taking for Ms. Naseem Yusuf. This question is from Lubna Ghazal. She's posting to everyone, but maybe to you. What do you think why younger age nurses, 25 to 35, have more critical results in your study?
Yeah. So I believe that these nurses, because they are not very, they are just new in their career. So they are just learning, they are just developing their psychological, they are just learning to make some emotions. So the nurses, because they are not very mature, so they are very quickly impacted by the environment they are working in. So they are more prone to develop very strong emotions, so they are more prone to develop satisfaction as well as the fatigue. So this is the best time when we can coach these nurses, when we can help them to identify this stress, and when we can help them to get over it. And this is the best time when we can prevent these nurses, because after 35 years of age they will like nurture whatever they have in their nature. But at this time we can really teach them, so they can more like they can observe it more than the nurses who are more mature.
Okay, so Mike, question to you will be, it's not a question but a request, since this study was done in the nurses working at Shaukat Khanum, so I would like you to please share your results with me as Director of Nursing. And I would like to work more with you and other speakers in the session of resilience to bring these strategies to help our nurses to, to cope with the situation and to develop their compassion satisfaction. Thank you, Naseem. Thank you for your participation and question.
Thank you.
So we had a very good discussion and 3 plenary sessions. Now we are going to shift to the our free paper sessions. There were many abstract invited, and of them for this session we have selected 3 free papers. Our next free paper, which will be presented in few minutes, is about challenges experienced by post-coronary artery bypass grafting patients. It's a qualitative study from Peshawar, Khyber Pakhtunkhwa, Pakistan, and the nursing colleague who is presenting is Israr Ahmed. He's working currently in Rufaida Nursing College, Prime Foundation, Peshawar, Pakistan. Over to you.
Assalamu alaikum. I'm Israr Ahmed with the topic challenges experienced by post-coronary artery bypass grafting patients. Qualitative study from Khyber Pakhtunkhwa, Peshawar, Pakistan. The mortality of coronary artery disease is increasing day by day, and it will be 25 million by the year 2025. And among 68% deaths from non-communicable diseases, the highest ratio, which is 48%, is due to cardiovascular diseases, and coronary artery bypass grafting is the most commonly performed procedure for the betterment and prognosis of patients with coronary artery diseases. About 20,000 CABG procedures were performed in Pakistan during the year 2016. CABG is a stressful event for all patients, and it affects both gender differently in the form of physical and psychological symptoms. Patient with post-CABG patients faces challenges like managing their daily life and family. Cardiovascular disease affects almost every aspect of human life, ranging from pain during walking to fear of death during sleeping. The first rationale is that CABG is the most common procedure for patients with coronary artery diseases. So that's why it was important to explore the experiences of such patients. Rationale number 2 is there is a paucity of research on experiences of post-CABG patients, and it is the first study of its nature to be conducted in Pakistan. Third rationale is that it may help the health authorities and nurses to realize the needs of post-CABG patients and plan the care to address their needs accordingly. The objective of this study was to explore the experiences of post-CABG patients in Pakistan. The design was phenomenology because we were going to explore the experiences. The setting was the Reading Hospital, Peshawar. Duration was 6 months. The sample size was 14. In qualitative studies, sample size depend upon data saturation. Data saturation means that when we have no new information from the participant. So it occurred on 13th interview, but we conducted one more to ensure the quality. The sampling technique was purposive sampling technique. Inclusion was patient living with post-CABG patient for at least 3 months and having age of 40 to 70 years. And the exclusion was a patient who were unwilling or having other chronic diseases. Approval was obtained from the KMU Ethics Board, permission was obtained from the Leading Hospital Peshawar, and consent was obtained from the participants. Participants were also provided information sheet to know about the study. Semi-structured interviews were conducted with the time allocation about 30 to 60 minutes. Data analysis, it occurred in 3 rounds. In the first round, there was open coding and or labeling. In the second round, the codes were characterized accordingly. And in the third round, relevant categories were selected to selective coding, and eventually themes were emerged. And the process that were carried out are: number 1, transcription, that is the transformation of audio form of the interview into written. The second was coding, process of labeling important information. The third was categories based on the essence of data. And the fourth was the theme development, in essence of categories, main ideas of the data, essence in the form of coding, and whole report. So we got 17 categories from the data analysis, and that leads to 4 themes. Number 1, challenges. Number 2, perception about CABG procedure. Number 3, coping with the challenges. Number 4, perception about nurses and doctors. So here is the demographic data. Most of the participants were male, and most of the participants were having age from 40 to 50. And the highest education was master. Almost all of the participants were married, and most of the participants were unable to work or retired. And all of the participants were having comorbidities. Dominantly, all of the participants were having history of MI. So here are the themes. You can see from left to right, theme with the concerned categories. Number 1 theme is challenges. Number 2 theme is perception about CABG procedure. Number 3 is coping with the challenges. And number 4 is perception about nurses and doctors. So here is the number 1 theme, challenges, and the categories you can see. And this is the description of the first theme, challenges. From left to right, you can see theme, then category, then code for each category or codes for each category, and then the direct codes or the patient statements for each code and category. The second theme, perception about CABG procedure with categories around. Description of the second theme. Third theme, coping with challenges, and also the categories. Description of the third theme. The fourth theme, perception about nurses and doctors. And the description of the fourth theme with direct statements from the patients supporting the theme. Conclusion. CABG was found to be one of the difficult, expensive, and challenging procedures that make the patient face certain physical, psychological, and financial challenges. These challenges need to be addressed. The strengths of the study were, the current study, to our knowledge, is the first to explore the post-CABG patient experiences and challenges in Peshawar. The second point is the contextual data gathered. The data was gathered related to the experiences of post-CABG patients as per the research objective. And the third point is that rigor or quality was maintained by following Lincoln and Guba's 1985 guidelines. Limitation. It was a single center study with a small sample size, and data saturation occurred on 14 post-CABG patients. While conducting interviews, it was observed that female patients were rare compared to male because they do not agree to undergo an operating. Certain cultural sensitivities also kept the number of female patients low. Recommendations. Further studies in the form of mixed method study designs are required for understanding the needs of post-CABG patients. Number two, health authorities need to make and implement policies for the betterment of patients after CABG. These are the references. Thank you.
Thank you. Nasir, would you like to take these questions to Mr. Israr?
Thank you very much, Madam Rehana. And I think it was indeed a good study at that part of the region to have this study on patients who underwent post-CABG experience. So there is one question from Ms. Farida. And her question is to Mr. Israr, that how soon after the CABG data was collected from these patients after the procedure? Mr. Israr, are you with us?
Israr,
So,
yeah, Israr doesn't seem here. I don't know.
the Israr is
So-
not here.
So we can post the question to him later on. We have few more questions about his study.
Yes. So we can proceed to our next presentation.
Yeah.
By that time, we can float that question to Israr, so we will be able to answer to that query.
Okay. Right. So our next presentation is about exploring the determinants of delayed diagnosis of breast cancer in the female population of Punjab. A nursing colleague, Samina Farooqi, is going to present this work of her. Ms. Samina Farooqi is working currently as a principal, Institute of Nursing, Advanced College of Nursing is named as, and the courses at this study was done under the umbrella of University of Health Sciences, Lahore. Over to you.
Assalamu alaikum. I'm Samina Farooqi, Principal, New Advanced College of Nursing, and today in today's session of Shaukat Khanum Cancer Symposium, I'm going to present my research work entitled Determinants of Delayed Diagnosis of Breast Cancer in Female Population of Punjab. So while I was working in the Shaukat Khanum Hospital, my major work experience was in breast surgery and breast cancer. So it was my concern that why the people in Punjab or the female in the Punjab are diagnosed at the late stages of the breast cancer, and what are the reasons behind it. So I took this topic to conduct a study, and it was a qualitative study. So while talking about the introduction and background of the study, we all know that the cancer is the major and leading cause of death in all over the world. After the heart diseases, breast cancer is the commonest in female and comprised 30% of all the cancers. From 2005 to 14, it was observed that the occurrence of the breast cancer has surged around the globe with a growing public health burden in low resource settings. In Pakistan, the rate of occurrence of breast cancer is highest, at 23% among all the cancers, whereas breast cancer is also responsible for the highest death rate at 16.1%. Furthermore, majority of the patients present at advanced stage, that's 50% at the stage 3 and 23% at the stage 4. Screening and early diagnosis is a key to reduce the mortality in the technologically advanced countries such as USA have the 5-year survival rate, 99% in localized cancer, 85% in the regional, 27% in the metastatic disease. And delay in the detection of breast cancer is associated with the large tumor size, involvement of the lymph nodes, and the poor prognosis after the surgery. Many reasons contribute to this delay. For instance, delay in the West Africa was observed due to the unaffordability and lack of awareness about the breast cancer symptom, and in Sudan, the most prevalent factor with the delay was financial constraints. While looking into the Asian context, Iran, India, and China present the similar picture that illustrates the low socioeconomic status, socio-cultural factors, religious background, lack of female physician, lack of awareness about the disease lead to the delay in the diagnosis of the breast cancer. This delay in the presentation and detection of the breast cancer with the patient with the breast cancer is the main contributor to the advanced stage at the presentation and increased mortality rate in Pakistan. Therefore, to address this dangerous issue in Pakistan, it was dire need to observe the actual reasons of delay between the appearance of symptom and the breast and the diagnosis of breast cancer. So objective of my presentation was to explore the in detail the phenomena of the delay in diagnosis of breast cancer and determine the reasons of the delay in the diagnosis among the female of Punjab. So the study design was qualitative study designed to study the in-depth phenomena of the breast cancer diagnosis delay, and the setting of my study was Jinnah Hospital, Gangaram Hospital, and Mayo Hospital, and study was conducted from August 2019 to December 2019. And total sample size of my study were 15 participants, and these were depending upon the principle of data saturation. Sampling techniques of non-probability purposes sampling and inclusion criteria were the patient or the female diagnosed with the breast cancer through history and pathological evidence. The age ranges from 30 to 65 years of the age, and diagnosis of the breast cancer after the 4 months of appearance of symptoms. So to collect the data, interview guide was developed that comprised of the two parts. First one, demographic characteristics of the patient, and the second one was focusing on the questions that were to determine the reasons of delay or the determinants of the delay of diagnosis of the breast cancer. So after institution review board of the UHS, I took the permission from the relevant hospital and selected the participants, and then done introduction with the participant and took their informed consent. Interview was recorded with the permission of the participants, and the total duration of interview was about 43 minutes, and it was in the Urdu language to facilitate the discussion with the participants. So the demographic characteristics of the participants were done with the inferential statistics, that's mean for the numeric and percentages for the categorical variables, and then the qualitative data or the verbatim of the participants were analyzed using the thematic analysis framework method. These are the demographic characteristics of the participants, and its majority of the females were married, and they were illiterate, and they have low socioeconomic status, and approximately 53% of the patients were diagnosed at the stage 3 and 40% at the stage 4, and the mean duration of delay was about 16.6 months. So the qualitative data results of my study were, the major themes were 3: personal psychological factor, socio-cultural factor, and the healthcare system related factor. And in these major themes, there were sub-themes, like in personal psychological factor was symptom appraisal, health beliefs, and use of alternative medicine was sub-themes that were related purely to the patient. A patient like the participant reported that they lacked the knowledge of breast cancer symptom, or they ignored the symptom because the tumor was painless, or it was related to the physical breast trauma, or the symptoms were benign, or they have the belief that the disease is given by the God, so he will heal, or the faith healer can heal it. And they took homeopathic treatment, Hakim treatment, and home remedies, and get delayed while consulting a medical practitioner or the medical treatment. And in socio-cultural factors, socioeconomic status was the major reason of delay, and social responsibilities such as household, children's, and work responsibility, and lack of social support. And cultural myths, like people in our rural areas think that the symptom appearing with the breast cancer are not related to breast cancer. They are actually Zaharbat, Chandris, or it's common for unmarried girl to have the symptoms. And the concept of cancer fatalism is very common. People get delayed in the diagnosis or the treatment because they think if they get treatment, they will die, or they will have to live with the breast cancer for their whole life. So the third major theme was healthcare system related factor, in which the physician behavior and healthcare system, facility were the main reasons, that whether the physician neglected their or the misdiagnosed their initial symptoms, and they got delayed. And the second thing was that the hospital near their home were very poorly facilitated, and they don't have the facility for the investigation to get confirmatory diagnosis. And multiple references and late appointment were also the reasons reported by the participants. So while concluding this session, it was reported that multiple personal, psychological, social, cultural, and healthcare system related factors were the determinant that were observed, and female from the low socioeconomic status are at the highest risk of diagnosis delay because of the poverty and lack of facilities. And moreover, lack of knowledge regarding the symptoms, use of alternative medicine, poor health practices, and economic hardship, treatment from the faith healer further deteriorate the condition. And so it can be rectified by the if if we acquaint with our female with the sufficient information about the different presentation of the breast cancer symptom, critical importance of seeking the medical help and treatment at the earliest, and implementing an intensive breast cancer awareness campaign addressing the myths and misconception will reduce the burden of the late stage of the cancer in Pakistani female. So outcome and utilization of the study are that the education screening program can be implemented at the community level on the targeted factors. Healthcare professional knowledge can be augmented to reduce the healthcare system delay, and developing the policies at the government level to ensure the proper checkup and screening at the high risk age group. And the finding of the study can also be implemented to conduct the large scale studies. So limitation of my study were that the finding cannot be generalized and data may have lost some exact meaning as it was transferred from Urdu to English, and some cultural terms such has no translation in English, such as Chandri, Zahar, Baat, Hakim, etc. So this is the link of my article, and these are the references used in my presentation. And now you are, thank you, and you are welcome for question answer session.
Thank you so very much. Due to time constraint, we may take this question in the end. I would like to invite the next presentation. We have our nursing lecturer practitioner presenting the systematic analysis or meta-analysis. Musarrat Parveen Hussain, a nursing lecturer practitioner from Shaukat Khanum. The topic of her presentation will be barriers in screening and treatment of breast cancer in women. This is a meta-analysis of research. Over to you.
Bismillahirrahmanirrahim. I am Musarrat Parveen, nursing lecturer and practitioner, and breast care nurse at Shaukat Khanum Memorial Cancer Hospital, Lahore. Today I am going to present my project about barriers in screening and treatment of breast cancer in women. Outline of my project are to identify the common barriers in screening and treatment of breast cancer, explore the strategies to address these barriers in timely diagnosis and treatment of breast cancer. Why I choose this study? Because breast cancer is the most common death-leading cancer in women globally, with 2,261,419 new cases were diagnosed in 2020. Worldwide, breast cancer presents 1 in 4 of all cancers in women. Since 2008, incidence of breast cancer has been increased by more than 20%, with increase in mortality by 14%. In Asia, cases of breast cancer are increasing rapidly, especially in Pakistan. 1 of every 9 women is at risk of getting breast cancer in her lifetime, and majority of cases are diagnosed in advanced stages, leading to poor prognosis. Best prognosis can be achieved only if detected in its initial stages. So it is important to explore the barriers in early detection of breast cancer in women worldwide. By addressing these hindrances on the way of early detection, survival rate of breast cancer would be increased. These three approaches are used to detect the breast cancer in its early stages. Those are breast cancer awareness or breast self-examination that should be started by every woman at the age of 20 on monthly basis. And if any abnormal change is noted, should be checked by physician, that is clinical breast examination. And the third one and the important one is screening mammography. Screening mammography should be started for all women at the age of 40, and those women who are at a high risk of getting breast cancer should start it earlier as recommended by their physicians. This study was based on meta-analysis of literature review that was searched through PubMed, Direct Science, Ovid, Medline, and Google Scholar. and all articles from 2011 to 2021 were chosen for this study, and terms used for this study were barriers, obstacles, fears, and challenges. Breast cancer diagnosis, early detection, strategies, and interventions. Selection criteria of my study was all articles about patients diagnosed and treated for breast cancer from different countries were included, and primary research articles, irrespective of research design, studies that identify the barriers to early diagnosis of breast cancer, and studies published in English language in the past 10 years were included in this study. And all these articles, those were excluded in my study, were articles about cancer screening other than breast cancer, researches about barriers to other cancer treatments, articles in other than English language, articles about non-cancer patients, studies published before 2011. After the review and analysis of 16 full research articles out of 101 articles, according to the selection criteria, all these articles result showed these 4 types of barriers on the way of early detection of breast cancer, which were personal barriers such as lack of awareness, fear of cancer diagnosis, work obligations, deterrent fears, embarrassment to hospital, examination, and consequences of cancer diagnosis. The second one was the financial barrier. That was also very important because having an awareness, a woman was unable to get the breast cancer screening or treatment due to her financial consequences, such as out-of-pocket money for services and some indirect costs like transportation, housing, children, and lost wages. And the third barrier to the early detection of breast cancer was structural barrier. That was such as geographic location of services, apathetic medical services, insufficient diagnostic or treatment services, shortage of resources, deficiency of supportive resources, long distance to referral facilities, high cost of diagnostic tests, long waiting time for diagnostic tests, lack of screening and diagnostic tests in local facilities, lack of physician and patient awareness. The fourth and very crucial barrier on the way of early detection was socio-cultural barrier. Socio-cultural barrier was, first of all, feminine sensitivity, aversion to male doctors, myths and misconceptions, taboo and stigmatization, discrimination, negative experiences, health insurance coverage, accessibility of healthcare services, fear of judgment, deterrent beliefs. By the synergetic interactions of these barriers, early detection of breast cancer is very difficult. Barriers to early detection of breast cancer are complex and associated with individual perception of patients, healthcare system, socio-cultural impact, and policy constraints. Investment in multi-level interventions could be helpful to address the barriers in early detection of breast cancer. In summary, these barriers are of 2 types. One is patient-related and other is system-related. Patient-related barriers are deficient in knowledge about breast cancer, negative perceptions about breast cancer, and financial constraints, which could be addressed by increasing health literacy and educate the woman about breast cancer, more awareness more awareness campaigns on media about breast cancer, promote breast self-examination in women, expand, and the other one is system related, that is lack of better health infrastructure, no effective policies for breast cancer, no record about breast cancer incidence. To overcome these systematic constraints, it should be addressed by expansion of health budget for advanced level care setups, introduction to innovative policies and training programs for breast cancer, develop a national level cancer registry. In conclusion, early detection of breast cancer is a best prevention, but most of the breast cancers are detected late as a result of complex barriers. These barriers associate with individual perception of patients, healthcare system, socio-cultural impact, and policy constraints. By synergetic interactions of these barriers, early detection of breast cancer is difficult. These barriers might be addressed through policy, health promotion, interventions for breast cancer awareness, and sufficient investment in multi-level approaches for early detection of breast cancer. Being a breast care nurse, my take-home message is there can be life after breast cancer, but the prerequisite is early detection, as stated by Anne Gillian. These are references which I have used for this literature review. Thank you.
So it was a thought-provoking this video, and there is one question we can take only because we have finished the time of the session. That question is from Lubna Ghazal to Smina. Lubna is asking Smina that in her data in the study, was there any indicative that this delay of screening is due to women's shyness? Smina, are you with us, and would you like to take this question?
Yes, ma'am. Actually, I have answered this question in my chat room too. That I have found it in the literature that there shyness is a reason in specifically in Asian cultures. But in my within my participants, no participant directly mention it as a reason. But they.
Yeah, but in Samina's, in Musarat's,
because of the negligence, they felt
but in Musarat's data analysis, we have answered to this question that shyness or cultural constraints could be one of the reasons for late detection. So with this, I would like to close the session. Thank you so very much, everybody who have joined us as a presenter. They have sent their videos, a lot of hard work behind their work, and sharing that work with us. Special thanks to Naseem Yusuf, Dr. Lalani, Andrew Dimek, because they have joined from the out range of their time of their countries to us. And thank you to Nashid Nasir, Bisharat, Musarat, all those have participated. Inshallah, see you all in our next session, which is a panel discussion starting at 14:15. So please be with us. Thank you so very much.
Okay, ji, Bismillahir-Rahmanir-Rahim. Assalamu alaikum to all of our viewers and our respected members in the panel. I am Nasir Khan. I am working as Assistant Director of Nursing in Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore. After a wonderful and very informative scientific first session of Oncological Nursing 1, now I welcome you all to the Oncological Nursing Session 2. Of the 20th Shaukat Khanum Memorial Cancer Hospital Cancer Symposium 2021. The theme of this session is developing compassion and dignity in nursing care. I'm sure it will be an excellent opportunity of learning, as we have outstanding nursing leaders from foreign as well as local, from nursing services as well as academia, and who will enlighten us from their experience and knowledge on this agenda, and we will be able to extract useful strategies to be utilized to enhance nursing. First, I want to introduce our honorable members of the panel. We have Dr. Nasreen Suleiman Lalani, who is assistant professor in Purdue University, Indiana, United States of America. Mr. Andrew Damick, who is acting chief nursing officer in Patriot McCallum Cancer Center, Victoria, Australia. Ms. Naseem Yusuf, who is working as oncology nurse in Cambridge University Hospitals, United Kingdom. Ms. Lubna Ghazal, who is the Dean of College of Nursing in Mukhtar Asia Hospital, Multan. And Ms. Rehana Ilahi, who is working as a Director of Nursing at Shaukat Khanum Memorial Cancer Hospital, Lahore. So about today's themes, we know that compassion is the human and moral part of care. According to many nursing literature, compassion is the philosophical foundation and centerpiece of nursing profession. Being compassionately responsive to the care needs of the patients is one of the professional standards of nursing. To highlight the concept of compassion and dignity in nursing, and considering the evidence-based practices and viewing this phenomena as a nursing expert, we will have keynote speaker, Dr. Nasreen Lalani, followed by panel discussion. So I want to now give over to Dr. Nasreen Lalani of a presentation on the compassion and dignity in nursing. So over to Dr. Nasreen Lalani.
Salam everyone, welcome to my presentation on developing compassion and dignity in nursing care. I'm Dr. Nasreen Lalani and I'm currently working at the Purdue University School of Nursing. Before joining Purdue University, I have provided nursing care in Pakistan for about 15 years in different positions as a bedside nurse, as a head nurse, as a manager, and then finally I was a faculty at the Khan University. So I'm very happy to give you a session on compassion and dignity in nursing care, which is a very important part of our care with our patients as well as our families. So these are the objectives of our today's presentation. So in this presentation, we will discuss what is compassion and dignity and why it is important in nursing or in any medical or caring profession. We will discuss the care needs and expectations of patients and families at the end of life care, discuss how nurses can incorporate the principles of compassion and dignity in their routine care. I will share some of the research findings on compassion and spirituality, which I did in a hospice setting in Pakistan. And then we will discuss some of the challenges that nurses and healthcare providers commonly face while providing compassionate care in their own settings. So let's discuss about what is compassion. Compassion is defined as suffering with or having a deep awareness about the suffering of other person, coupled with a wish that how we can relieve it. So compassion is not just a feeling. It's about the action. It's about acknowledging that the other person is suffering and how I can relieve or act to respond to that suffering. The essential components of compassion include recognizing suffering, relating to individuals in suffering, and reacting to suffering. Whereas dignity is defined as respect, worth, non-discrimination, or being non-judgmental about the other person. Dignity is a subjective concept and it can be viewed differently in different cultures. For example, the care about the older people are seen different in Western culture and then Eastern culture. There are different concepts that relates to dignity about autonomy and relationships, which may be viewed differently in different cultures. So what are the principles of compassion? The number one principle of compassion is to be kind, to be non-judgmental towards the self rather than being self-critical. The other important principle for having compassion is to be mindfulness, which is about how we tolerate the distress and how we hold the painful feelings, and whether we are aware of those feelings and how we handle those feelings rather than over-identifying with them. The third principle is having the deep sense of humanity, having the deep sense that the other person is suffering and we want to help that other person. Seeing the one suffering as part of human condition rather than as isolating. So again, it means to be kind, to be understandable, to be able to acknowledge and to see the other, to be able to see the other human suffering and to be able to help that human in that suffering. So it's all about empathy, connecting, understanding, and acknowledging. So here I would like to show you one YouTube video, which is just less than 2 minutes, and it tells you that how we sometimes become so judgmental that we are unable to understand or acknowledge the other person's suffering. So let's watch it.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Oh, come on.
Ow.
If you would just
Don't.
Try to see things my way. I have to keep on talking to.
So I apologize for some technical issues that the video cannot be played. So we are trying if we can have that video, and we can, because
so
this
will
be.
You have enjoyed this video, and you must have realized that sometimes we start to judge the people, or sometimes we try to fix the problem rather than acknowledging or listening to the concerns of the other person. And that's very important when we talk about compassion or acknowledging other person's suffering. So moving to the next slide. So what are the benefits of compassion and dignity? So most of the research have shown that when we care for patients and families compassionately, it improves the clinical outcomes. It increases the patient satisfaction with services and enhances the quality of information gathered from patient. And here I would like to share some of the real examples that I have seen during my own clinical experience, during my own journey of nursing. And I remember that way back when I was a student, the first time I went to a hospice setting, and there I saw a lady. And she was married with only one girl. And she was, at that time, she was 60 years old. And she was suffering from terminal stages of breast cancer. The breast cancer has all metastasized in her body. She was unable to get out of the bed. And I remember there were very few staff who could just take her out of the bed, give her adequate care. So for me, it was the first time. She was all in pain. She had a big open wound on her chest till the abdomen. Luckily, she has not developed any bed sores. So I just went to her, and she was kind of announced that she will die, and it's only been some weeks of her life. And I was like, I couldn't figure it out. Like, I was a second year student at that time, and I was thinking, like, how can I help her? Because sometimes we only think about the medications, the painkillers, or the dressing, or the other technical aspects. So I said, like, how should I help her? What can I do for her? And then I started hearing her story. And she told me that when she was only 13, she got married to a man double her age. And her daughter is now married, and her husband is also addict. So there was a suffering of her daughter. There was a difficult life that she has always been through. She does not have very good relationship with her husband, and her husband has always kind of did a lot of violence on her. She has suffered domestic violence, other abuses in her life. And still at the end of life, she told me, which was very surprising, that her husband is actually, he actually took the photos of her wound, of her chest, because she had breast cancer. And you know that for a female, how sensitive that part is. And her husband has taken those photos, and he is actually using those photos to bag money. And he's using those photos on bus rides and other places to bag money for her treatment. And imagine, like, for that woman, knowing that her husband is doing those things to get the money for her treatment, and like showing her sensitive part of the body. How difficult would be that? How difficult that would be for that woman, for that particular lady. And then knowing that she never had good relationship with her husband. She never felt love, kindness from her husband. And then now again, her daughter is also having the same life. She's continuing the same life. And her daughter has TB, and she is living with a husband who is drug addict. So for that woman, I realized that it is not just the suffering of the illness. She might not be much worried that she will die, or she has that big wound, or she is on the bed and she cannot move. But there were a lot of other associated sufferings to her, which I wouldn't have known if I wouldn't have listened to her compassionately. If I wouldn't have acknowledged it, if I wouldn't have sat with her, if I wouldn't have talked to her while giving little physical care. And I remember she was bedridden for about a month. And then after I tried to build a relationship with her, I was listening to her story. I was listening to her suffering. I was acknowledging that. And we kind of built a trust relationship among each other. And then after 2 or 3 weeks, she was ready to sit on a wheelchair, and I took her outside for just a walk, or like she was on a wheelchair. So I just took her to the garden, which was outside the hospice. And she was so happy, and she loved the nature. And I could see that peace, that calm on her face and on herself. Like she was able to come out of the bed, sit on the wheelchair. That was one positive clinical outcome. And then the peace and the calm that I saw on her face, whatever life she is remained with. But then for few moments, I felt it very rewarding that I could give her some peace, some calm through my care, just listening to her and acknowledging her suffering. So that's very important. And sometimes we don't realize those important things in our care. We just think about medication, we just think about painkillers, we just think about bed care, we just think about preventing bed sore. But these things, just listening and acknowledging the other person's suffering, and suffering is not about the illness only. Every person that comes to the hospital comes with a whole history. They come with their own stories and they want you to listen to them and acknowledge their things. And it just gives them peace, motivation, and improves their clinical outcomes. So this was a real story. There were a lot of other stories that I went through when I became a nurse or a researcher, and I went to the families to listen to their stories during my research, and I'll share that research with you. And there was a man who didn't wanted to give me interview for my research, but then one day he said, okay, I can talk to you. And then he told me all about his story, and I remember at the end he said a sentence. Initially, he was not ready to say things to me. He said, I don't have time and I can just give you 15 minutes. But then when he started talking, he talked about more than an hour. It was the longest interview I had during my research. And I remember the end part that he told me that today I said things which I have never said in my life. And I am thankful that I could say that in this life and in this 1 hour. And now I feel so relaxed and so refreshing that I can give care to my patient, regardless of whatever suffering or whatever I am missing, because he had a daughter and he was taking care of his father-in-law and he couldn't go to his home for about last 6 months. And now he's told me that now after ventilating my feelings, after sharing my feelings with you, now I can care for my father-in-law much better. And I'm feeling less depressed and less in sorrow. So it's very important. Sometimes we don't recognize those things. Sometimes we don't realize that how important these things for that patient or that family caregiver, and it literally improves their clinical outcomes. Yes, it improves their satisfaction, and yes, it improves their quality of life. So now, as I said, that I will share some of my research findings, and my research was about the spirituality, the experiences of spirituality, and we know that compassion and spirituality goes hand in hand. And I asked in my study that was done in a hospice setting in Karachi, Pakistan, and I interviewed family caregivers and I asked them that how do they experience being a family caregiver for a patient who is near to death or who are dying. So these are some of the experiences, and I will share some of the themes that I collected in my research finding. And the first theme was that we need to be compassionate, and being compassionate means helping the patients and families cope with their loss, grief, and suffering. So we all know that the dying experience is associated with fear, denial, and anxiety for a patient or for a family caregivers. And healthcare professionals in my study felt the need to understand patient and family concerns, needs, and preferences during end-of-life care. In times of suffering, spiritual issues become the central concern and therefore should be the focus of care. That's what the healthcare providers told me. And compassionate care help the individuals to transcend their difficulties and sufferings and it aids them in their personal growth and self-transformation. One of the healthcare provider said that we know that we cannot improve their quality of life, but by listening to them, by giving compassionate care to them, we can at least increase their quality of life. And I remember one of the family caregiver told me that when the staff ignores us, everything seems to be failing. But when they listen to us, just their one gesture or smile give us a sense of personal growth. It gives us a sense of satisfaction, and it gives us peace within ourselves. So you can imagine how important providing the compassionate care to our patients is. The other important theme that I got in my study was showing dignity and treating the individuals as a person. And I think that's very important because sometimes we tend to discriminate our patients, our families on the basis of socioeconomic status, on the basis of race or gender, but this is not showing dignity. Showing dignity means that we provide the care without any discrimination. And that's very important. And you can see in these, so compassionate care is not about identifying and treating problems. However, it's about being there, understanding the suffering of the patients and families, connecting and serving them with love and affection. The third theme of my study was sense of attachment and belongingness. And healthcare professionals and family healthcare professionals verbalized that it was difficult working in a hospice setting. However, this place has become a part of them. And I remember one of the physicians told me that it was very difficult for her to decide to join a hospice setting because she knew that there she has to go through a lot of sufferings and she will see a lot of deaths, which might be very painful and difficult for us. But now, after working in that hospice setting, she feels that she's part of it. She has developed that sense of attachment and belongingness. And I think that comes with time. When we be part of that system, we tend to get attached to that system and we tend to get attached to that place. And then when we have this belongingness and attachment, we find whatever care we provide to our patients and family rewarding. And it gives us a sense of fulfillment and satisfaction. The other thing is that is very important is understanding the cultural and religious values. We know that sometimes when the patients are in hospital or hospice settings, they have need to follow their own cultural beliefs and their own religion. Sometimes they don't know that being on bed, whether they can read the Quran or they can recite prayers. We have to make sure that we listen to their concerns because those are the things that actually provide them peace and satisfaction. And we are there to facilitate them. So we need to tell them that, okay, we can say that our religion is not that strict and it's flexible. And if you want to recite your prayers, maybe these are some other alternative ways, or we can provide them rosary, or we can provide them things where they can recite, do their recitations and feel safe. They have the space, and then they find the peace and they find the satisfaction while giving the care to their patients. And even for the patients, we can tell them some alternative choices where they can attend to their religious and cultural values. And that's very important. And that's also part of our compassionate care. So yes, so those are some of the ways, and those were some of the themes from my own research. And that also relates to our own, when in our real settings, when we give care in our own practical settings. But I know that there are some barriers to develop compassion and dignity. And what are those barriers? So sometimes we don't see the patient as a human, we just see them as a bed number. And it feels very odd when we say, or the patient here, that bed number 110 needs medication. Do we think that's right, or that is humanistic? Or if we should identify that person with name or give some respect. So that's about giving respect and providing the dignity to the patient. So don't see the patient just as a bed number, see him as a human. And they are not with their illness only. They have other feelings, other concerns with them too. And we need to be mindful of that. Again, there are time constraints. So many of you must be feeling that sometimes we don't have time to listen to the patient, to acknowledge their feelings. And that's true, because I have also worked on bedside. We sometimes become so much task oriented that we think about, like, we have to do medications, we have to do documentation, we have to make rounds, we have to do the orders. But then I think prioritizing your things and just doing some kind of time management and just giving 2 minutes, 5 minutes, and does not take much time to just sit with the patient, just touch the patient and ask and make them feel that you are there for them. I think we can do these little things, not many. It takes only 5 minutes to listen to the patient. Sometimes it just takes some few seconds to touch the patient and to make them feel that yes, you are there and you are present for them. Yes, workload. Sometimes if there is no workload distribution, I know that there are in some areas the staff is being given like 20 patients per one staff, or sometimes 30 patients. So staff distribution is also very important if we want to provide compassionate and dignity to our patients and families. So distribute, like giving adequate amount of workload would help the staff to provide such kind of care. And that's also the responsibility of the organization and how we distribute the staff in our own settings. Communication skills are also very important. Sometimes we are not comfortable talking about the spirituality of the patient. Sometimes we are not comfortable talking about the death and dying issues of the patient. Sometimes we are not comfortable to talk to them about their family issues and other concerns. They might have sexual concerns. They might have other relationship concerns. So yeah, the trainings are needed for those things. And then we know that there is a lot of education practice gap. Sometimes we are not told in our curriculum that how to deal with those scenarios and those situations. So that is also important. And the hospital policies, I know that if the hospital policies are not staff friendly, it becomes very difficult for the staff to provide the compassionate and dignified care to the patients and families. So these are again some strategies which we have already talked around the barriers. It's important that what is our own personal value system and belief system is. If we find, I think we all are nurses and we all have this compassion quality in ourselves, otherwise we wouldn't have been nurses. So it's an inherent quality. So it also depends what our personal value is, how we want to see the patient or the family and how we want to help them. So sometimes it just comes from your inner motive, your inner motivation. Having the self-awareness is also very important. Adopting a person-centered approach, having a supportive environment, and then some training programs to help us to become and utilize more compassionate, caring, and dignity with our patients is very important. Then this is the last slide, and I think this is the very important. Our self-care is also very important. Sometimes we work in such a busy environment and we go through a lot of things with our patients and families, and it's not easy to be a nurse or a doctor or work in a caring profession because we face a lot of challenges during our work, listening to all those stories and dealing with different kind of people with different personalities, different behaviors. Sometimes we have visitor issues, and there are a lot of issues because they are also humans and we are also human. So we do suffer then as a nurse, as a doctor, as a healthcare professionals also while working with those difficult patients, difficult families in a difficult work environment. So our own self-care is very important. And for our own self-care, we should have good meals, we should have good sleep, and we should have some opportunities to develop our own relationships. Taking care of our own relationship with our own family, friends, and relatives is very important. And then we can have some time to attend programs such as mindfulness programs. We can do deep breathing exercises if we are stressed out or if we are feeling depressed while being in the hospital, or if the workload is very high. So we can do some to de-stress ourselves. We can go into some mindfulness classes, we can do deep breathing, we can go in some counseling, we can go for some counseling session, or simple things like ventilating with our friends, with our family, and building a good relationship with them. It's very important, and sometimes it's organizational responsibility also to provide us with those support programs to improve our mental health, because that's also very important if we want to continue with giving compassionate care and dignified care to our patients. So thank you very much. And if you have any questions or concerns, I'm happy to respond. And my email is written here. It's lalanian@purdue.edu. And thank you very much for giving this opportunity. And I wish you all the best in your careers.
Thank you very much, Dr. Nasreen. I think it was a very wonderful and very clear overview of the theme, and it's very difficult to make it clear to our nurses that how they can practice compassion. And the golden words which I have noted down as that compassion is not only feeling, but it's all about actions, and it's all about reacting to a sufferer. And we know that patient is coming to us not with only illness, but it's a whole history of illness. So a very, very painful experience. To elaborate more on the theme, we have divided the panel discussion into 3 themes. Number one, we will ask our expert and panelists that what is the nature of compassion and its dimension. How can we prepare our healthcare workers to practice compassion and empathy in their practice? And how can we improve and provide supportive environment to our staff so that they can show their compassion and dignity in provided care. So I would like to ask Ms. Lubna Ghazal, who is also a mental health nurse and have worked very closely on this agenda, that how do you see integration of mental health concepts into compassion and dignity of a patient? Ji, Ms. Lubna.
Assalamu alaikum everyone, and Nasreen, it was very wonderful session. I think you've thoroughly talked about, I think, every panelist, what they have to speak today. So yes, Nasir, thank you. And thank you, Shaukat Khanum, for giving me a chance to participate as a panelist. So yes, there is a very strong relationship between compassionate care and mental health. So for that, I think we need to first understand the function of our prefrontal cortex. So there are, list of functions, but I would like to, focus on 9 functions of prefrontal cortex, which relates to care and compassion. So first of all, it regulates our body function. It helps us communicate in better manner. It helps us create emotional balance. It helps us, respond through reflex flexibility. When I say reflex flexibility, it means that everyone has communication skills, whether we respond or whether we react to a situation. So, in terms of positive psychology, it is always recommended that we respond to, to a person rather reacting to the conversation. It also, the prefrontal cortex also help us develop empathy. It also gives us ability to intuit well, so that we can take very, appropriate action in certain situation. It also boosts our morality, insight. It modulates fear. And when it comes to cancer patients, they admit with lots of fear, anxiety, and depression. Of course, so these are the 9 functions of prefrontal cortex, and these are the functions that we as nurses, as healthcare providers, we need to stimulate these functions. So in physical health, we all have always learned that someone going gym to build muscles and everything. So on the softer side, we also need to boost our neuron and neuron pathways of our neuron to make a healthier prefrontal cortex, so that we can utilize this in the benefit, not only in the benefit of patients, but also colleague relationships and working with leadership in our healthcare setup, etc. So you see, there's a strong relationship of one's mental health and compassionate care.
Ji, thank you very much, Ms. Lubna. I think it is very complex phenomena, but you have well elaborated in a very clear message that we should see this phenomena in our care, and we can take that to our nursing care plan. So thank you, Ms. Lubna. Now I would like to ask Ms. Rehana Ilahi, who is the nursing services leader, that how do you see nature of compassion and its dimension? Ji, Madam Rehana.
Thank you, Nasir. And I must say, take opportunity to thank you, my panelists, because they have been busy with me for the previous few months, preparing and recording their presentations. And, this day today or the weekend, and in a different region with different time span, they are still, sitting fresh and participating. So this is what actually is compassion. So as Dr. Lalani said, that compassion is defined as a suffering with or awareness of suffering of others and wishing to solve their problems. So it's a very unique concept. It is a very unique phenomena which has multi-dimension. As we all know that patient in general and cancer patient in particular, when they walk into the hospital, they are bearing a great degree of stress. They are suffering, they have pains, and they're under that great stress about their health. They expect us to be kind to them. They expect us to be respectful to them. They do not expect only that we resolve their physical problems, we give them good quality, safe care, but and relieve their suffering, pain, and feel comfortable. But also, they expect us that we are providing them peace, and we are actually putting them on comfortable positions. We are putting them in a comfortable environment, and that comes through compassionate care. So the nature of compassion is about giving and having time. It's like multidimensional phenomena, as I said. It is involving attentiveness, listening, confronting the patient, involvement of patient, and total of yourself. It's about helping. It's about your presence, not only physical, but your total presence and understanding about. So these are the dimensions of compassion. So I would just throw light on them. The major dimension of compassion is a temporal aspect of it, which is giving and having time. So it requires about providing information to the patient about their health, their disease, or maybe the treatment trajectory. As a healthcare provider, time is a major constraint, always a major constraint and major barrier to convey our expression, our compassion to the patient. Whereas somebody who is suffering and is under stress physically and mentally, what the person needs most of your time. The time where you can listen to their concerns thoroughly, you can explain your responses in detail, and you're available and accessible to discuss those concerns time and again when they occur. So temporal aspect of compassion is a very strong aspect. The literature says that compassion is an innate quality. There are a number of studies which reveal that innate quality of respect, dignity, and care, which is in the healthcare provider before they start their clinical practice, become a baseline to provide a compassionate care before they started and to nurture the attitude, compassionate attitude in them. On the other hand, it says that it can be nurtured and taught. It can be nurtured and taught through the role modeling of their seniors. The seniors who are taking care of patients during their clinical practice, they exhibit commitment, they exhibit persistence and dedicated presence to the patient and their families that give a role model or a perception to the junior or to the starter or the beginner that what is compassionate care. So as I mentioned earlier that there is a strong concept, there's strong dimension of, and Dr. Nasreen also have mentioned that strong dimension of compassion is an active listening. So since the beginning of our nursing career, it is always emphasized on active listening or attentive listening. Why it is needed? Because attentive listening actually it helps us to connect ourselves with our patient as a person, not as a vessel of disease. So as a person, and every person coming to the hospital, coming to you or in your clinical area, come for help. Their need of health are unique. Their experiences with the disease are unique. Their experiences with the treatment trajectory are unique. And particularly in cancer setting is totally different. Those who have worked in general setting and then move to the cancer setting as nurses, they understand that there's a huge difference between working with patient having general problem and working with patient having cancer problem, because the disease and its treatment is prolonged. The patient become part of the hospital and they grow in front of you. They grow, the pediatric especially, they grow in front of you while having treatment. So they have unique experiences of suffering, which require nurses to know their feelings and their perception of disease, their perception of their problem, and respecting their point of view. And this approach actually advocates the respect of patient individuality, which leads to an empathetic response. So there are several studies which have reported that compassion is conveyed through attentive, attuned, and mindful listening. What is mindful listening? It is sitting with the patient, listening to them as well as observing their non-verbal clues. What is their body language telling us? Do they have tear in their eyes? Are they trembling? Have they pale face? Are they sweating? Can you see, them restless? So all those non-verbal clues, and then sitting with the patient silently, using your effective silence to understand what is happening to them. That is the important dimension. And the very much nature of compassion is about involving patient and their family in care and involving yourself totally into managing their care. Providing them information. This can be demonstrated by clarifying information to them, not hiding information, encouraging them to share what do they think, what do they feel, what do they want, what is their perspective of their problem, and communicating effectively those information to your multidisciplinary team and other care providers so that the care can be coordinated. So coordinated care is another aspect of compassionate care. So patient required to confront their fears. They require to confront their worries, their anxieties with the help. So how you can help them? With the help of mindful and attentive listening, you can help them to confront their fears and to combat those fears. So if we lack the concern, the respect, or if we are reluctant to talk if we are reluctant to share with the patient, that become a barrier between patient and us providing compassionate care. So here I believe that we may not be able to increase their time in life, particularly when they have cancer or they have end-stage disease or their loved one has cancer and haven't. But we can do every effort to enhance their experience with us and with our organization. Yeah, thank you.
Thank you, Ms. Rehana. It was a clear overview of on the dimensions. And you have well said that it is an innate quality, but we can teach this to our nurses and from academia till they work independently. So here is our next theme, which is healthcare worker preparedness on caring with compassion and empathy. And first, I want to float a question, and I would like to ask Ms. Naseem Yusuf, who have been there in the clinical setting very closely with novice nurses and developing them in the cancer setting, where patients have not only a fear of uncertainty, but they have a fear of certainty because they have a cancer, which is itself is a big threat to life. So, Ms. Naseem, if you can tell us that how can we introduce or teach compassion in nursing to our novice nurses or nursing students?
Thank you very much, Mr. Nasser. So to start with, I will first refer to Ms. Rehana's statement, where she says that compassion is something innate. So still there is a certain level of ambiguities. There is a certain level of uncertainties if we are able to teach compassion. Because those who favor that the compassion is something fixed in the personality, is something innate, they do believe that if it is not there, it's not there. And any sort of teaching can be fruitless. And like how we can force somebody to act against their nature. So of course, it's going to be very, very hard to change the nature, of course, after a certain age, maybe. So, and then if we are in an idea of teaching compassion, if we still believe that, yes, we can teach the compassion, then the first thing is that it is to be started at as early as possible. Like once after a certain age, when the people become fixed in their ideas, when their minds are not open anymore, then of course it would not be worth teaching them. And again, like my study, the age of 25 to 35 is more sensitive age. This is the age of emotions, I would say. So this is the age that is best we can use to teach the nurses. So how can we teach? Coming to this question, we first need to know that how compassion is conveyed. Like if we said somebody is a nurse is very, very compassionate nurse, what we look forward in that nurse. Like if I generally take it, it's like empathy. We may say that this nurse is very empathetic, or the character of that particular nurse, their interpersonal skills, their communication, their competence, and all that. So in order to teach the compassion, we can teach the skills that can help the nurses to be more compassionate. Yeah. For instance, we can help them improving their communication skills. We can help them in learning the interpersonal skills. We can teach them critical thinking skills. You know, critical thinking is another thing that has very important role in compassion, because the nurses who are more critical, they can be fast acting, and of course the patient can perceive them very compassionate, because the compassion is not only towards the patients. Compassion is not only towards the patient care. We need to be compassionate with our colleagues. We need to be compassionate to ourselves as well. So we have to have critical thinking. And then like emotional intelligence is very important. Our level of compassion will definitely decrease when we come across the negative feelings. So in order to overcome the negative feelings, we should be able to manage our own feelings, our own emotions. So we need to be emotional intelligence. So if we can teach these skills of our nurses, self-reflections, self-knowing, confidence, culture awareness, and the things like that, so we can really teach them compassion. This is what I believe, and this is like in scientific literature as well. So in addition to teaching the nurses these skills, we really need to provide them a well-supported clinical environment. Because even if a nurse is emotionally intelligent, a nurse has critical thinking skills, or the nurse is like use reflective practice, but she does not have the time due to the time constraint in the clinical area. She does not have the time to think on to act, or like the clinical situation can be really very stress provoking, highly demanding, and sometimes very conflicting due to the shortage and all that. So we really need to provide them a supportive clinical environment. And like in here in England, the NMC, they have refined the like the compassion into 6 C's. They believe in 6 C's for the compassionate care. There's care, compassion, courage, communication, commitment, and competence. So everyone needs to everyone's care needs on the communication needs to revolve around these 6 C's. So if we talk about teaching these skills like critical thinking, emotional intelligence, reflection, and everything, we really need to refine our education methods and our tools. And like we can use scenario-based learning in our clinical areas, or as well as in the classroom teaching. We can use reflective practice, role modeling, discussions, group activities, and the strategies like that, and which can really help to make our nurses more compassionate.
Thank you very much, Ms. Naseem. I think you have covered all the aspects of that. How can we educate and coach on nurses, especially those who are new to the system, and while they are caring of such critical patients who are undergoing such a major disease. I agree that it's hard to change, but we have nurse educators like Ms. Lubna Ghazal, who have worked hardly in mental health nursing, and she's Dean of the College of Nursing. So let's ask her that how should we build the capacity of nurses to practice compassion and dignity in cancer care? Ms. Lubna.
Thank you, Nasser. And I would like to, respond to your question in 2 steps. First of all, we should know that what is the current evidence that tell us that there is a, compassion fatigue or compassion crisis. So I would like to share with you some of the evidences that I, just grabbed from the current evidences, and they clearly tells us that there is compassion fatigue and crisis among healthcare providers. So I would like to talk about a study which was conducted in Sweden, and this was based on an accident in 2007. Whereby there were a bus who was carrying 56 passengers, and they met accident. Out of these 56 passengers, 6 died, and then the researchers retrospectively went to these passengers and asked them what they have remembered during this whole accident and recovery process and survival process. So, so this was a qualitative study, and what the researchers have found, they found that these survivors remembered 2 important things. One was the physical pain. The other thing was that they mentioned that they found healthcare providers with lack of compassion. So they dealt with us with lack of compassion, and their communication skills were very poor, and they were not listening to our concerns. So these were the things which they remembered, and it gives me a big concern that why would have these healthcare provider have provided such care. If we look at an evidence from Harvard University, which was conducted on physicians, and basically, and what they have found, they've asked physicians about compassionate care. So they said, yes, we would love to provide compassionate care, but we do not have time. So the 50% of physicians reported that they do not have time to provide compassionate care. And then this tells me that, okay, if they do not have time, then if if some of the healthcare providers providing compassionate care, what are the findings, what are the positive findings out of compassionate care? So here I would like to also mention research which was conducted again in USA on lung cancer patients. So there was a huge funding into this study, and there was 2 interventions. So they've asked patients if they want to have aggressive treatment of cancer, or they choose the palliative care, compassionate palliative care. So and between these 2 interventions, they've divided patients, and what they have found after comparison. So they measure 3 outcomes. The other was the survival length. The third thing was cost. And they found that those who have chosen the aggressive cancer treatment, the depression rate was more than 40%, while patients in the palliative arm were only 16% of depression. The other thing is the survival length. So the patients in the aggressive treatment for cancer lost their life within 7-8 months, while the patients with palliative care who were working with nurses and doctors and receiving good communication and caring, so they survived more than a year. So, there is a clear evidence that compassionate care makes a difference. Then cost, of course, the patients who were under aggressive treatment, the cost was high versus the palliative care intervention where they were using communication skills, empathetic approaches. The cost was none. They have, managed within their staff, and the cost was very, very cheap. So, these are the evidences which tells us that yes, compassionate care is required, and it is also bringing positive outcome on the patient's, survival rate, the quality of life, etc. So yes, there is a need to develop capacity of nurses. Now, this is the second part of my response, that yes, we need to develop capacity among nurses, healthcare providers, but the question is how. So like my colleagues Rehana and Naseem mentioned, that it is innate quality. Yes, in some people, this may be innate quality, but literature also suggests that we can build the capacity to develop compassion, care, empathy, good communication skills while we are dealing with patients, listening to them, etc. So from where we have to start? So as Rehana also mentioned that, these are very sensitive professions, like nurses and doctors. These are very sensitive professions. We have to deal with patients, their pain, their caregiver pains. It's very complex. So, from the beginning, when we interview these, candidates who wants to come into nursing or in the doctor's profession, we need to, identify those people who have this ability to nurture in the field as a compassionate professionals. So at that time, from that time, we need to start, selecting appropriate people for the profession. On the second level comes the curriculum. So, in the curriculum and, being an academician, I understand that, yes, the nursing curriculum, 4-year BSN curriculum in Pakistan does have, compassionate care within their curriculum, but in the bits and pieces. So, we have to, compile all this concept into some modular learning. And from the beginning, we need to give them from their curriculum, undergraduate curriculum, we need to start developing their capacity. Then comes the teaching learning methodology, Nasser. So, we have been very traditional in our teaching learning approaches. And I think the new, teaching learning methodology, evidence-based methodologies are coming up, like simulation, like problem-based learning. We need to utilize these teaching learning methodology to simulate such, scenarios with our patients, like breaking the bad news, which is very, very relevant with cancer and oncology nursing practice. So we need to simulate such scenario, for instance, and then, make them, start their capacity from the undergraduate curriculum development. And then comes the continue professional education. We need to now have an interdisciplinary approach. We need to make doctors and nurses sit in one class, and we need to develop certain specialized module, maybe cancer nursing, maybe for other chronic illnesses and palliation, and we need to teach them in one class. For example, again, I will take the example of breaking bad news. So it is the responsibility of physician to break the news, but then what is the responsibility of nurse in the same scenario? So we need to develop certain teaching learning methodology, which with the help of this we can teach nurses and physician work collaboratively and serve particularly the cancer patient, whereby we need these in very, very sensitive manner. So these were my thoughts, how we can build the capacity into nurses and healthcare providers.
Thank you, Ms. Lubna. I think it was a wonderful response to have a clear view as how can we develop capacity of nurses. And yes, from curriculum till we have a multidisciplinary team, so we can promote compassion among nurses and physicians through collective teaching and learning. So I would like to take Dr. Nasreen Lalani, and I would like to ask her that how can we measure compassion in care? Are there any tool or any scales to measure it? Yes, Dr. Nasreen.
Yeah, thank you. And I am just loving the discussion. It's 5 a.m. here, almost 6 now. But it's so interesting that I can't stay away. So that's a good question. Yes, we can measure compassion, and there are different scales available in the literature. The most commonly used compassion scale is by NEF, and it's a 21-item scale, and it's a Likert scale from 1 to 5. 1 is never, and 5 is almost always. And basically, the compassion scale items are based on 3 major components. One is kindness, the other is mindfulness, and the third one is humanity. So there are several statements around these 3 important aspects where they measure the ability, the self-compassionate abilities in an individual. The scale has been translated into different language, and I was just checking the literature that it has been translated into 19 languages, including Persian, Germany, and other languages. Whereas I didn't see any Urdu translation, so definitely our new upcoming researchers may like to have this research project maybe in their studies, and they can do the validation, the translation, and the reliability of the scale. So it's not impossible. It's not something that is impossible, and we can do it for sure. And like I have seen in different studies that compassion scale has been kind of associated with resilience scales and post-traumatic growth scales. So that's another area to look into. So yeah, and there are other scales also available, but the NAF scale is most commonly used in the literature.
Thank you very much, Dr. Nasreen. I would like to thank you all, like sitting in the middle of the world. We have like you are sitting, thank you very much. And it's 5 a.m. there, and we have Induced who is sitting in the region where it's 5 p.m. So we are almost 24/7 covering this symposium. Thank you very much. Andrew, if you can tell us, how should we empower our nurses to provide compassionate care? Andrew.
Very important.
Hello, everybody. Thank you very much. And thank you, Nasir and Rahana, for inviting me along. It's an absolute pleasure to be here again with you all. I learn something every time, and the amount of work that everyone does is just absolutely fantastic. And everyone should be really, really pleased about all the research and all the information that's coming out today. So the way that I would look at this is in terms of how we empower our nurses is to provide the compassionate care is looking at 3 different aspects: demonstrating our leadership, listening and learning to our patients' experience, and supporting our nurses or our personnel or staff. So from a leadership perspective, it's how we then all demonstrate our leadership. So moving from a position of power in any particular role that we may be in, and to a position of serving the team or working alongside the team. So also that's also demonstrating how we support our individuals to develop that potential. So earlier on, we heard about how we can nurture and harness our junior nurses, particularly around how they can deliver care. And if we as leaders, and we all are leaders as nurses, irrespective of our role or title, we're leading the care of our patients and we're leading the care of our departments and our teams. So I think even when we're looking at different scenarios in healthcare, when we have to use different leadership styles. So when we have to be very authoritative in an emergency, or we can be very democratic. There's always ways that we can still show compassion despite the challenge or the situation we're in. And I think just reflecting on my own practice, particularly around the last 2 years or so with COVID, and again, it's thinking about how we role model, how you go to a particular ward and you show compassion to the patient, but also how you show compassion to the staff or the team that you're working with. And again, once again, no matter what our role or title is, we are nurses and we're able to demonstrate that on a day-to-day basis. So I think if then the next thing is really around that patient's experience. So lots and lots of research and literature around about what patient's experience is. But for us, again, it's looking at the context, the culture, the country or the region where that patient is, and how that fits in with all of their areas that we're working in. Dr. Nazreen spoke earlier about knowing the patient's name, and particularly when you go to an area, it's always not calling them by a bed number or going onto ward and asking for a patient in a certain bed or an area. It's asking what is that person's name and responding in that particular way. And that's really important for us, particularly in our nursing handovers and also in the ways that we look at results or tests and talking about people, not about numbers. So again, I think it's really about what do patients perceive, and we have to ask them. So in many ways, patients describe their experience by what they see, what they hear, and what they feel in clinical areas. And many of us have been a patient, and you hear and you see a lot when you're sitting there, not much to do. But again, it's really understanding that descriptive accounts from patients' perspective and teaching our junior nurses or letting them listen to those patients' accounts is really important. So an area around that is around that knowing me and giving me your time. So when you're looking through the literature, there's a lot of work around what patients see, hear, or feel. And what they describe is care or caring is mentioned by all, but the connection between care and compassion is very, very blurred, or the same thing in many ways for a patient. But what we're trying to do is trying to put ourselves in that patient's position. So again, how we empower our nurses is getting them to think about what it's like to be that patient. And as we've all talked about, time is a real key thing here. And particularly around, it's instrumental about giving people the right time to be able to care compassionately. The other thing is around what patients describe is where they observe, although a ward may be busy or a department is very busy, the time that somebody still takes to listen, as Rahana has said earlier, listening, actively listening, that's what the patients remember. So we can demonstrate that to and empower our nurses to see that it's still okay to be able to give that time, and you are doing something constructive by listening and spending the time with the patient and not just doing a task. So again, we just have to be very clear about those things. And that also an issue about the differentiation between sympathy and empathy. So also understanding the impact of compassion and how will they feel in their shoes. So again, looking at, we're trying to alleviate suffering, but also to appreciate what is going on for that individual. We also have to identify and promote that this is an important part of our care. The other areas around is being more compassionate and the essence of nursing communication. So being mindful of our style, looking at the language we use, making sure it's appropriate for the person that we're looking after, and not just looking at the particular things that we need to do. So look at that ward culture of the department. So we don't just need to get a job done, but we have to listen and pull that whole care together. One particular example is about having a particular, for a patient, is about me board. So displayed by the patient with information that is pertinent to them, name that they prefer to be called, TV programs they like, those type of things. Again, it brings a human nature to that patient. And then from an organizational perspective, it's looking at the surveys. So feedback, surveys, national or local cancer patient experience surveys. And in many ways now, as we go ahead, is that co-design of our care or our care planning with the patients themselves. And then finally, in this area is around that personal. So what do we do with our nursing staff? So we have to look at our systems and our values and our beliefs and understand that we all have differences, but we also have very, very similarities as well. And again, it's looking at how we then question our values as nurses and as caregivers. So things like our nonverbal communication. So going back there, yes, we might be busy, but we can still take the time to listen and not walk past somebody when you can see that they want to ask you something. Looking at the culture of the area, supporting our colleagues, being consistent with our approach, and looking at the organization's values and its vision. And just to end on this section here is around supporting our nurses, that self-care and self-compassion. Again, when you're looking at the literature, the more that we look after ourselves, the more we're able to look after our patients. And that comparison shows that the more that we do that, then we get better outcomes. So self-kindness, mindfulness, etc., what we've heard all about today. So it's again, coming back to that point about listening to our staff, listening to our patients, and having the organizational structure to make sure that we can empower our nurses to continue to live that compassionate care.
Thank you, Andrew. I think it is very important to tune very minor actions like giving time to patients and listening to them. It's not a big deal to sit with them just for a few minutes. I think it is a big impact. It will a big this will be an impact on the patient as psychological comfort. I would like to ask Dr. Nasreen, as she has been involved as a head nurse and as a manager in a well-established hospital, that how can we inform compassion in our individual actions or behaviors, as well as in policies at leadership level? Dr. Nasreen.
Thank you for this question. I think most of the part has been answered by the other panelists, and Andrew touched upon that we need to, number one is self-care. And I think that's the most ignored part that we make in our own roles. And that's the most powerful act that has a powerful impact on our own actions and behaviors. So unless we concentrate on our self-care and then again, like taking good meals and having good sleep, like these are the physical things that we need to do, but they also have impacts on our own actions and our own caring behaviors. Because if we ourselves are frustrated, if we are hungry, if we are not taking our breaks on time, then obviously it will come into our reaction, and then we won't be able to show the care, the compassionate care or the kindness. It won't come in us. So it's so natural. Sometimes we don't, most often we ignore those things. Those things are very important. And then how as leaders, we demonstrate our own leadership. What role modeling do we provide to our patients? That's very important, because when I was a bed nurse, I had a head nurse who was very strict. And she was like, if I do a little mistake, like, because when you are new on and you are new into your role as novice nurses, you do make mistakes. But then the leaders should be able to show respect and should understand and should be supportive and should not ridicule you in front of the patients. This is something which is very important that we need to keep in mind, that we need to respect the other person as well as we have to respect ourselves. So we need to respect our own needs as well as we need to show dignity and respect to our own colleagues. So we need to show that role modeling, and that's very important, because whatever we are, we will transfer or communicate the similar things to our juniors. And we must have remembered this idiom for nurses, like nurses eat young nurses. We shouldn't be like that. Otherwise, we won't be able to empower. We need to empower ourselves, and then we need to empower others. So that's very important. The other things we talked about, the workload issues, the staffing ratios, if those are not being handled at the policy level or at the organizational level, obviously the nurse would not be able to show compassion, because if she doesn't have that time, she won't be able to show that kindness, that humanity. We cannot expect those things from them. So that's also very important. And then providing them the incentives. Incentives can be in any form. Just 2 words of recognition can show a lot of support, or advocating the nurse, or talking on behalf of your nurse. If you see that if a physician is, or a consultant is ridiculing your nurse or your colleague, you can advocate for them. So I think those skills are also very important. So just showing support to your own colleagues, being a role model and taking care of yourself, having some self-care activities, and providing incentives, providing little recognitions in terms of words, in terms of finance, in terms of gifts, monetary, everything counts for any nurse or for any human to be compassionate. So I think that's my message.
Yeah, thank you, Dr. Nasreen. And yes, at leadership level, we have to be role models, and we should provide non-punitive environment to enhance nurses to practice compassion. And even little words that you have said, that they can change nurses' approach to a more compassionate approach. We have services leader, Ms. Rehana Ilahi, Director of Nursing at Shaukat Khanum Memorial Cancer Hospital. I would like to ask, what is the relationship in compassion, satisfaction, and patient load in clinical setting? Ms. Rehana.
Thank you, Nasir. There's a lot been said, and I'm really fascinating from the discussion. It's going to be a successful session of one of our symposium. I would take this discussion or this question into 2 folds. First is, what is the relationship between the burnout, nurses' burnout and their patient load? And then what is the relationship between nurse compassion, satisfaction, and burnout? So as we all know that nurses face a wide range of challenges when they are taking care of their patient and their families. While nurses are a very important part of healthcare because of both their compassion and care and their skills at bedside. So they can become stressed and burn out, particularly when they're working in critical environment, like one of ours in oncology or ICU or cardiac setup. So compassion satisfaction is essential of nurses today, I would rather say. For that, we need to understand what is compassion satisfaction. The literally definition of compassion satisfaction is that it is a pleasure or a happiness someone derives from being able to help others or to do their work at their best capacity, at their best ability. And lack of compassion satisfaction can lead to compassion fatigue, which we have heard from Naseem this morning in our research. Compassion fatigue affects the care providers and then the patient, because the care provider who is affected, who is fatigued, who hasn't had compassion, the care will not be compassionate. So compassion fatigue then leads to nurses burnout, which is a physical, mental, and what you call it, exhaustion, emotional exhaustion, and it can lead to nurses disengagement. Disengagement could be physical. Nurses leave the job, change the job, go to another profession, or maybe change the country, right? And it could be a mental disengagement, which is that the nurse is in the job or is continuing job, like what is happening in Pakistan, when people do in country like us, when people do not have much opportunities to work in different professions. So they become mentally disengaged. So they're not very much interested. They show lack of interest in work. So they will do their task, but it will not be like their total self or total involvement in it. So nurses spend countless time and energy managing their patient and ensuring patient safety, particularly in nowadays environment, and also monitoring patients' clinical deterioration and then reporting those deterioration, performing their task to ensure that patients are getting high quality service, high quality care. So providing high quality care and safe patient care requires a good number of nurses, an adequate balance of workload, an adequate share of work to them. Because quality of care is directly related to the nurse's ability to interact with the patient. So to provide compassionate care, the nurse's ability become less. It is lessened by a higher number of patients as compared to the adequate or required or a standard number or a standard load or a standard caseload or patient load, whatever you call it. Because quality of care is directly related. So how can you expect somebody providing quality of care when the person is not feeling into it, when the person do not have time to provide that compassionate care? So what will they do is, we're not going to measure their compassion, but we're going to measure, have they given the medicine? Have they completed the documentation? Have they provided the food? Have they done the hygiene of the patient? So they will do all these things, but their self into the patient care will not be seen. And even balance between compassion satisfaction, burnout, and compassion fatigue should be achieved in the workplace as well as in the nurse's self-life, their life, personal life. There should be a balance. This is only possible if we acknowledge the significance of burnout, which is affecting nurses' compassion satisfaction and which is causing compassion fatigue in them. So a significant relationship has been found in studies between burnout, compassion satisfaction, that showed that a workload increases, the burnout increases, and the compassion satisfaction decreases. So there are a number of studies which have shown this. So an increased workload contributes to increased stress and cause burnout among nurses. And nurses who took advantage of their employer, their intervention to reduce burnout or compassion fatigue, they then take the compassion satisfaction. Their compassion satisfaction increases. So due to nature of their job, we all know, we all are nurses. Due to nature of our job, nurses experience traumatic event in EAR, in operating room, in accident and emergency, when they're caring for their patient and families, when they have working in pediatric oncology, when they're working in medical oncology. So the overwhelming demand to meet the care expectations and the expectation of the management actually lead to increase their stress. This is another type of work, meeting the expectation of the management. As you know, the audits, the results, the accreditation, a lot of certifications which are now coming for nurses to be achieved. So that increase their stress, that increase their emotional exhaustion, and that increase their job dissatisfaction and burnout, and that lead to decrease nurses' compassion satisfaction. Now, this burnout and compassion fatigue affect compassion satisfaction, as we discussed earlier. The nurses become overwhelmed, their wellness is on stake, and their work environment is not very much healthy for them. So this could lead to adverse reaction for the patient as well as for the nurse. This could lead to cause the nurses to leave their profession, as we said earlier. So when they leave their profession, or they leave the organization, those who left with have to share the burden. So then this will be a vicious cycle of increased burnout, leading to increased compassion fatigue, leading to decreased compassion satisfaction. Moreover, nurses required to deal with the situation, including high patient acuities, like in ICU, in cardiac care, in oncology, and they have to make critical decisions about patient care, or they become part of those critical decisions. They like DNR, like quitting the support in ICU, and they have professional conflicts with other multidisciplinary team or nurses among nurses. or they have situations which are conflicting with their morale, like euthanasia and all those situations. So this thing add up to their workload. This thing add up to their stress, and this also affect their compassion satisfaction. So work or patient load is usually high in critical care area, like environment of ours, oncology settings. Research also have shown that generally nurses exhibit an average level of compassion satisfaction. But nurses working in critical care have lower level of compassion satisfaction. So it is very important for them to maintain a healthy balance between good and bad patient care aspects, good and bad aspects of patient care and experiences, which are directly related to burnout, compassion fatigue, and decreasing compassion satisfaction. So as we all know that more seasoned nurses who were able to take the stress and have good compassion satisfactions are leaving bedside care. So the nurses, they're fading out from the organization. So the nurses, the younger nurses, younger generations, the generation of nurses is found to be reporting significantly higher level of burnout, and early burnout, and compassion fatigue, and in turn, lower level of compassion satisfaction. So that means, and it is supported again by the literature, that maybe the level of experience or probably the maturity or age, as Naseem have mentioned in the morning in her talk, in her study, play a major role in managing burnout, compassion fatigue, and develop compassion satisfaction. So probably we will be knowing from Andrew that how can we combat this challenge. Thank you, Nasir.
Gigi. So yes, at leadership level, I think we are measuring almost everything, but we should also measure while using the tools that Dr. Nasreen have also shared, that there are tools available. We need to measure the compassion according to that scale and identify the need for further improvement. So yes, Mr. Andrew, if you can tell us very briefly that workload and staffing ratios are major challenges. How can we avoid or tackle these barriers in the provision of compassionate care to our patients and their families?
Great, thank you. So I think we'll start off with we're all dealing with people, whether we're nurses or patients. It's one thing, people. We need time to provide care, and we're all challenged with shortages of staff. So recruitment and retention are challenges internationally. And again, it's how we as nurses individually and collectively influence policy. So again, we all understand it's that organizational culture, and that support is from the top, no matter what role we're in. And looking at leadership, and whether a nurse or an executive or a medical colleague, again, we can all demonstrate the compassion. And it's important that that compassion from the organization is in everybody's mind and demonstrated across the whole organization. So if we think about the environments we work in, they're big, they're busy, we have lots of family. COVID sometimes has changed that, but again, people are around, and again, that sometimes limits the amount of time that we're able to give compassionate care. However, that should not be a restriction. We'll also have very small spaces at times. So if we then look at what the routines that our nurses are working in, whether they work in team-based care, if they're doing task-orientated, or whether they're working with mandated ratios. So within that, we're considering about the skill mix. Where do we get these people from? And look at whether there's registered nurses, enrolled nurses, support workers, and again, looking at how we can utilize those people appropriately. We know more and more, there's less registered nurses. So again, it's where do we find those skills that we need to deliver? When we were talking a little bit earlier about our workload. So and again, we looked at that inconsistency about what work is given out to different registered nurses. So particularly when we're looking at a ward, for example, is what is the supervisory role doing? Do we have somebody who's able to support the junior nurses to deliver the care without taking a patient load? And really importantly, and particularly what's happened in the pandemic, is making sure that we keep our educators free to be able to support and educate the staff and again, demonstrate care. But when we are challenged, we then have to sometimes push the number of people we have. Looking at how we then influence policymakers, again, is looking at how we use that information we have. So acuity and dependency tools. So understanding what care our patients need and how we can demonstrate that to the policymakers around why we need extra staff to be able to deliver the care, and compassionate care particularly. So we then look at that ratios. So many parts of the world have different ratios. So where I'm working now in Victoria, there's a mandated or in law that there is one registered nurse to 4 patients. Now that's not everywhere, but again, you can have a mandated ratio, but if you don't have the staff to fill that ratio, it's very challenging. So we then have to think about how we do that with our current staff that we do have. So just going back to that point on our breaks and our handover time, particularly how we look after our people. So making sure we facilitate that, giving people the time to have rest, having safety huddles so people can understand what's going well and what's not going well in our clinical areas. And particularly looking at those team meetings as well.
Yes, Andrew, sorry,
Yes.
Our next session, the participants, they are waiting. Thank you very much. And you have in earlier your talk that you have well highlighted that how can we measure our staffing and all those nurses, nursing shortage and all those. So thank you very much. Thank you very much to all our members in the panel across the globe. Ms. Lubna, Ms. Naseem, Ms. Rehana Ilahi, Dr. Nasreen Suleiman Lalani, Mr. Andrew. Thank you very much. Take care and Allah Hafiz.
Very welcome.